Royal Commission is now in session.
Yes, Mr.
Commissioners, I call Dr. Kathleen Matthews and Nicole Storm.
Further associates?
Dr. Matthews, do you solemnly and sincerely declare and affirm that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say I do.
I do.
Ms. Storman, do you solemnly and sincerely declare and affirm that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say I do.
I do.
Ms. Hill?
Ms. Storm, please state your full name.
Apologies, could you please repeat that for me? I had audio fail.
Certainly. Could you please state your full name?
Nicole Lauren Storman.
And you are a registered general dental practitioner in the Division of an Oral Health Therapist,
I am.
and you're in the final stages of your PhD, as I understand.
I am.
And you are currently the Vice President of the Australian Dental and Oral Health Therapists Association.
I am.
And for the purposes of the hearings this week, you prepared a statement for the Royal Commission.
Yes.
And have you got a copy of that statement in front of you?
Yes, I do.
Operator, could you please display document ID RCD stop 9999 stop 0299 stop 0001? Whilst that's being brought up, can I confirm with you that that statement was dated 12 March 2020?
Yes.
And were there any changes or amendments that you seek to make to that statement?
No.
And are the contents of that statement true and correct?
Yes, they are.
And do you see a copy of that statement to which we've just referred on the monitor before you?
Yes, I do.
You've also prepared a response to propositions that the Royal Commission has asked you to consider, dated 16 April 2020.
Yes.
And you've got a copy of that in front of you.
Yes, I do.
And if I could ask the operator to please display document ID RCD stop 9999 stop 0316 stop 0001. And do you see that response to propositions that we've just referred to on the monitor there in front of you?
Yes, I do.
Commissioners, I tender the statement and Ms. Stormer's response to propositions as a bundle.
Yes, the two documents will be Exhibit 17-10.
Dr. Matthews, could I ask you to please state your full name?
Kathleen Ann Matthews.
And Dr. Matthews, you're a senior dentist at the Wagga Wagga cluster in the Murrumbidgee region of New South Wales, working in both private and public practice.
Yes.
And you're currently a board member and are serving as the president of the New South Wales branch of the Australian Dental Association. Is that correct?
Yes, I am.
And in advance of your appearance this morning, you prepared a statement for the Royal Commission.
Yes, I did.
Operator, could I ask you to please display document ID RCD stop 9999 stop 0302 stop 0001. Whilst that's being brought up, could I ask you whether you've got a copy of that statement in front of you?
Yes, I do.
And that statement is dated 17 March 2020.
Yes, it is.
And are there any changes you'd seek to make to that statement?
No, there is not.
And are the contents of that statement true and correct?
Yes, they are.
In addition to your statement, you've also prepared a response to the propositions that the Royal Commission has asked you to consider, haven't you?
Yes.
And have you got a copy of those responses dated 23 March 2020 in front of you?
Yes, I do.
And before I ask for that document to be brought up, could I confirm that you can see a copy of the statement to which we've just referred on the monitor in front of you?
Yes, I can.
And if I could ask the operator to please display document ID RCD stop 9999 stop 0310 stop 00001. And do you see a copy of that response document which we've just described?
Yes, I do.
Commissioner, I seek to tender Dr. Matthews' statement and response to propositions as a bundle.
Yes, two documents will be Exhibit 17-11.
Staying with you, Dr. Matthews, how did you get interested in the dental and oral health of older Australians?
It's a personal story for me. I bought a practice from an older dentist, and the cohort of people that I was mainly seeing was older. And as they got older, and I got older alongside them, they're a bit older than me, what I started to notice is that their oral health was deteriorating before my eyes. And I realised that for something to change, I couldn't be fixing one mouth at a time. I had to think about the systems that were supporting them. So that led me to think about how I would change my practice and how I would influence my community. So I elected to seek work within the public sector and have worked very solidly since about 2011 now to establish outreach services into aged care facilities around the region.
Dr. Matthews, as part of those outreach services that you're involved in, how often would you be seeing recipients of aged care services?
So our program now is established that it goes out twice a week the Murrumbidgee is a very large geographic footprint. There's lots of little what's called MPSs, which is a multi-purpose centre that have aged care beds. So there might be a little bush hospital, so to speak, with 5 or 10 aged care beds in it, and they're the residents of those little communities live in those. So we have a kind of a circuit, I suppose, might be the way you think about it, where we send out an oral health therapist and a dental assistant to those facilities, and that service leaves the Wagga, which is the hub, twice a week. Things have been a little bit slowed down, obviously, with COVID at the moment, but that's the plan, yeah.
And Dr. Matthews, as part of those outreach services, do you work with oral health therapists and other oral health practitioners?
Yeah, so our service has a visiting oral surgeon, it has dentists and dental officers, we have a private practice dentist that we outsource work to, and we have employed oral health therapists within our workforce that make up the oral health expertise, and then a dental assistant, and our dental assistants usually have some formal qualification as well.
Ms. Stallman, turning to you, could I ask you to describe to the Commissioners what work the oral health therapist does and how the oral health therapist is able to respond to the oral and dental health needs of the older population?
Thank you for that question. Yes, so I suppose within the scope of practice of an oral health therapist, as well as a dental therapist or dental hygienist, because we do have different divisions of registration, each have different scopes of practice, but from an undergraduate training perspective, oral health therapists have with elderly Australians, a preventive focus. So when we see an elderly patient, it would be our role to assess their oral health, identify risk factors, train other personal care workers, nursing staff, and say carers or caregivers, as well as the elderly person, to maintain their oral health. We then do have skills where we can undertake treatment in elderly patients. So we could be, say, for example, some feedback disappeared for me. We could be, say, prescribing particular regimes. We could be doing periodontal treatment. But then things that are not within our scope of practice, we would refer appropriately to another dental practitioner or other allied health practitioner. For example, we might identify other systemic issues that might require, say, a dietitian, nutritionist, nurse, for example.
Staying with you, Ms. Stallman, but I'll address this question to you also, Dr. Matthews. How is it that the dentistry professions and the non-dentistry professions and allied health professions more broadly can address the deficit that you've described in your statements as to oral and dental health care of older Australians?
So I believe this is a multifaceted issue, and I sort of touched briefly when I was describing the role of an oral health therapist in that the needs of the oral health needs of elderly Australians can be viewed from a preventive perspective and then also a treatment perspective. So Dr. Matthews touched on the fact that with ageing, we see deterioration of general health and oral health, which indicates that there would be a need for treatment. But just as importantly, there is also a need for prevention. So this is what we would perceive as the initial line of care. And so in addressing the oral health needs, I believe that there's a preventive model of care that would be a solution to that, and then also a treatment-based model of care to address the oral health needs. And both of those have different solutions, and they're quite complex in the context of how dentistry currently is more broadly and how aged care currently is structured, and they don't seem to integrate well. So I'm unsure if I answered your question, but I think I've just introduced a very complex issue that we're trying to address here.
And we're here to find out how to fix it. So thank you. Dr. Matthews, would you like to respond to the evidence that Ms. Stallman has given and address that question, please?
Yeah, so I think she's got it right. It is complex, and what we see is the inability of older Australians to access oral health expertise and oral health knowledge, and we see that the care systems that are around them also demonstrate a lack of oral health knowledge. So for us, embedding some sort of oral health champion and someone with training is a really key to identifying the problems and actually installing and maintaining and initiating that preventive care cycle and then escalating to a treatment care cycle if that needs to happen. I think that's really key, is that most, looking at it as an oral health practitioner myself or a dentist, I can, look at someone's teeth probably via a camera or with my own eyes and have so much information in front of me, but that's because I speak the language of teeth. And I think that the majority of caregivers don't speak the language of teeth, for want of a better word, and I don't think our medical colleagues are also trained. So I think that what we're talking about is embedding some oral health expertise and some care pathways and some access for people whose independence and frailty is now impacted to the point where they lived in supportive care environments. So that's what it looks like for me. It looks like bringing some expertise in to facilities or into home care situations so that something doesn't go overlooked until it's become grossly diseased or grossly infected and those sorts of things. So Nicole, talking about a preventive, foundational preventive care program and with pathways to access appropriate care is really key.
Propositions D1 and D4 contemplate an outreach dental model in combination with funding for oral health therapists in aged care settings. Dr. Matthews, do you see parallels between a combination of the first proposition that we've asked you to consider and that fourth proposition and your own model of care that you engage?
I think if I'm understanding you correctly, you're talking the funding needs to happen. Is that, sorry, can you just rephrase that? Yeah.
I will. So in respect of your statement, you describe at page 5 that your preference is for an outreach service.
Yeah.
And ultimately, you describe in your statement a dental team. Does that dental team model that you engaged in your practice reflect those outcomes that you want to see?
Absolutely. So the team that I work with are passionate about oral health, and our oral health therapist is the linchpin, for want of a better word, in terms of they're the person that can walk in and I talked about, my eyes being, they're being my eyes, I suppose, for someone that's a treatment-focused professional. So they can gather a lot of information. They can also give a lot of education, and they can also give a lot of motivation and be that team coordinator. Which dental team member needs to come in to assist or not, that's really key. So knowing when to push the emergency button, or whether to no, that's okay, we can do this in a more structured way. So I think that's the key role, is that having that trained registered professional sitting there being the advocate for the patient and having oral health knowledge that allows them to escalate or de-escalate as needed.
And returning to the propositions, where D1 is a funding of public dental services to provide outreach services to Australians accessing aged care services, and that's achieved. Are you able to hear me?
Yeah, it just faded out for the last half of that sentence.
I was asking you about proposition D1, which is at page 8 of the draft proposition.
Yep.
And D4, which is over the page on page 11.
Yep.
D1 being the funding of outreach services through a new national partnership agreement to fund public dental services to provide outreach services. And D4, a proposition which contemplates establishing a new mechanism to fund organisations to supply all hygienists and dental and health therapists to residential aged care.
Sorry, Ms. Hill, that last sentence faded out again.
My apologies. I've taken you to D1.
Yep.
And looking at D4, which is a funding for services to be delivered by oral hygienists and dental and oral health therapists in residential aged care facilities. Would the combination of those two propositions, if enacted, satisfy what your preference is for a model?
Yeah, I think it would. I think that we need to think creatively and flexibly about how we embed oral health and oral health care pathways into residential aged care facilities. And I think that this mechanism where we have a registered professional almost being a gatekeeper, but as I said before, able to escalate and de-escalate is a really key part to it. And I think the reality is that they're a key part of the workforce in being able to deliver a preventive and oral health, to be able to deliver oral health assessment and preventive care. That's a really key part of the role that oral health therapists can play, and actually advocating for residents to get access to the right dental team member, because it's well within their scope. Getting access to the right dental team member to deliver the appropriate care to the right person at the right time.
Dr. Matthews, what else would you like to see in terms of adding or amendment to those propositions for a best practice model?
So what else would I like to... Sorry, can you repeat that?
What would you like to see in addition to those two propositions that I've taken you to?
Yeah, so I think that we need to establish that oral health is a risk for older Australians. And if it deteriorates, it can go unnoticed. So we'd like to think around getting some sort of mandated oral health assessment as part of an ACAT when you enter a residential aged care facility, when you're in transition to aged care, or when perhaps you've arrived at hospital as an older person and are in a geriatric care ward. I think there's opportunities there to gather information and assess oral health that are being missed because the pathways aren't established. So for us, I think having oral health is one of the key parts of aged care assessment, whether it's in the GPs, it's triggered as a referral via the GP to a qualified oral health practitioner, or whether it's, within public hospitals where there might be a dental team, that can visit. That's what happens at our hospital. So I think that is the other part of it, is actually raising the profile, creating awareness within the community, and particularly within our medical and health colleagues, so that's one of the little things that gets assessed. We know that people have wounds assessed. We know we have their feet assessed. There's lots of other assessment that goes on, but not a lot of oral health assessment happens without passionate people driving that in local situations. And so mandating oral health as part of general health and as part of the personal and clinical care that is delivered to aged care residents is a really important part of driving change in this area.
Ms. Stallman, how do we raise the public awareness, the profile of oral and dental healthcare needs of older Australians in the community? Is it through including it in the ACAP process that Dr. Matthews has just referred to? Can the GP get involved?
Yes. Again, this is the multifaceted approach that we've suggested that's evidence-based. I think nothing that we're saying is anecdotal. Researchers have tested it, and we believe that these are the solutions. We just need to be able to implement them, and the system is fighting against us. And yes, I do believe the assessment is important. We have to consider how it would be implemented. Because looking at the literature, when general health practitioners do look in the mouth, they don't know what they're looking at, and things do get missed. So what Dr. Matthews was saying is that we need someone who is appropriately trained to be able to do that assessment, not dismissing the fact that GPs and nurses can look in the mouth and notice gross problems. But I think there does need to be connections and awareness at those initial points where we are already seeing elderly people within the community before they enter residential aged care facilities. So at those touch points, wherever we have the opportunity to insert oral health as an assessment, I think that would be appropriate. And then raising the profile of oral health, I think, would naturally happen by integrating us within residential aged care facilities, because naturally at the moment we're quite siloed, we're forgotten about. So if we did have dental professionals within residential aged care facilities, naturally we become part of the team, and we become part of the broader health bubble that we've been missing from for a long time. So I think it is really important from just an integration point of view that will raise oral health's profile and importance more broadly.
And Dr. Stallman, Ms. Stallman, in respect of your stated preference for a model that tackles both prevention and treatment together, which you refer to in your statement at paragraph 8, and considering those two propositions that I've just taken Dr. Matthews to, do you see D1 and D4 as the best approach for achieving those preventive and treatment needs? Are there other matters that the Commissioners should have front of mind when they're looking at this issue?
For D1, when we look at how our dental services are currently structured, public sector oral health services are quite limited, just naturally from the way that we are with our private sector, and we do have limited capacities, and that's why I do agree with D1 in that we do need to review the partnership agreement. We need to review the funding model, because if they are going to be helping provide that treatment-driven focus, that can be costly and time-consuming, and that's why a lot of, say, the gold standard models of care, like Dr. Matthews' community, does not always get implemented, and we usually have a lot of vulnerable people missing out on care. So reviewing that, I think, is key to ensuring that they are able to deliver the services that they need to do effective outreach and to the most vulnerable people. And then, yes, so I'm not sure if I answered your question.
Thank you. In terms of what Ms. Stallman has just said, Dr. Matthews, and you've been given the gold standard
No.
reference. What, in your view, can be done to implement what's happening in your region more broadly? Is there the capacity for what's happening in your part of New South Wales, where you talked about you described a circuit arrangement of sorts, to be involved in aged care services where people are in the home? And is this approach that you've adopted capable of being achieved more broadly?
Yeah, so I think in Wagga we have a private model of care too, where we're able to arrange that person to go into homes, and he does. So that model could be scaled, and that's we wrote that in our submission. And I think where the confusion is for lots of people is around the kind of dual funding model, I suppose, for aged care, because the aged care beds that I'm reaching are part of state-funded facilities. And I think the irony of it for me is that I live in Wagga. However, the aged care facilities within Wagga aren't state-funded; they are federally funded. So there's a kind of a gap there for the members of the community. So we can fill that gap because I have access to a private dentist that I can outsource the treatment for if the patient qualifies, and also all those patients can self-fund their treatment as well. So other patients could self-fund. But it's about getting that oral health practitioner in the door and getting the model of care driven and supported. So I think that what needs to happen is probably, for me, a collaboration between those kind of two funding models that don't appear to support the same members of my community in the same way, I think is probably what I'm saying. And I think that we need to think creatively, because not all models of care will suit all locations. I'm talking about, I live in rural regional New South Wales, so a circuit type arrangement works, and the addition of a preventive and treatment, and prevention delivered as part of the assessment is probably how it will continue. But in larger facilities, there's an opportunity to perhaps have an oral health expert on staff. That might be how it looks, what it looks like, an oral health therapist on staff. So I think that what Nicole and I are both saying here is that, oral health is important, and we have to look at ways that we can scale models and bring it to a point where oral health is an important part of the care that is delivered within an aged care facility or within a community care arrangement as well. And so it would need to be a more flexible, portable outreach model than perhaps in a facility where there might be a space that's able to be utilised, those sorts of things. So I think that there's not one perfect model of care that will fit all situations. It's got to be designed to fit the situation that's presenting.
And do you have a view as to how a funding model or funding models could reflect those different needs that you've described?
Yeah, so I suppose, looking around the environment at the moment, there's a child dental benefit scheme that delivers dental services to children that qualify, and that's around Family Tax Benefit A. Now, I think that the ADA is very keen on thinking about a seniors dental benefit scheme where, oral health assessment is, an automatic kind of thing for older Australians, and there's several referral pathways into it. But then perhaps if they need supplementary, so they need prevention or treatment, then maybe there's a funding pathway via a Medicare scheme called something like the Senior Dental Benefit Scheme, for want of something better. And that's the mechanism I see working, because the public dental services are able to utilise the child dental benefit. So theoretically, that could deliver similar sorts of outcomes for senior older Australians. And I think the key to it is to see the problem and then think about mechanisms that could help. Yeah.
Ms. Stallman, reflecting on Dr. Matthews' answer that she's just given, and coming back to that point which you described with the need to bring oral and dental health professionals into the team that cares for the aged care recipient, do you exercise a preference for a model such as the child dental benefits scheme which Dr. Matthews has described? What do you want to see from a funding model or models?
So for the preventive model that we've been speaking about, my preference would be funding directly to the facility itself. This is my preference because it would ensure accountability, that the facility is required to spend the funding on this, and this would ensure our integration and oral health integration within that particular setting. If for a preventive focus we were to say have some kind of senior dental benefits, I believe the most vulnerable people would miss out because there is no insurance that all these people actually access this scheme. And if we have a look at the child dental benefits as a parallel, we had severe underutilisation with excellent intent for the scheme itself. But I fear that that would also repeat. We'd have the proactive groups utilising a scheme for that, and we would still perhaps face some barriers to integration. So I see for the preventive model that going straight to the facility itself, where we can implement appropriate rules. If we can ensure that they're going to be spending that money on that, then we know that that's going to occur. So it's not just give them money, make them accountable for it as well. Then when we look at the treatment model, I think this is a different answer. And when we look at the private and the public sector of dental services, different models of funding work in different ways. And as Dr. Matthews indicated, the public sector is quite strapped, and a senior dental benefit scheme could perhaps address some of the needs for the treatment-driven model, but definitely not the preventive model. But again, it depends on where you want to try and overcome barriers to accessing care. So if we're not then reviewing the MPA and looking at the public sector and how they deliver care, we're not really mandating the use of these funds. We're just putting the money out there and we're saying that you can potentially use it to increase care. So I fear that we're going to be privileging some elderly Australians, and that we will still have inequities in care, and that the lower, the poorest oral health groups in elderly will not benefit from a scheme like that. So it's a fine line to walk when you're looking at a treatment model, and how do we improve that? We're working between two systems that are not perfect, and what do I believe is the best solution from a treatment-driven perspective? I think it's reviewing public sector funding models and ensuring some kind of accountability in there to support them to be able to do the jobs that we know they can do well, and that we can review and not put the responsibility in the individual families or a proactive aged care facility to ensure that they receive treatment. So I hope that explains the two systems that I believe need different approaches in terms of funding.
And with respect, Ms. Stallman, to your preference that the funding in the treatment model is held by the provider, and a desire to hold the facility to account, what would you be looking for? What do you say are the mechanisms that and accreditation of that facility, of that provider's oral and dental healthcare attention to those needs of its residents can be effectively
there's different approaches to it, and I suppose it would be looking at system level data that they collect, and ensuring that, I'm sure they collect systems level information on other health outcomes of the residents, but ensuring that they're collecting routinely oral health information, that they're reporting this upwards, to report that oral health was being addressed. So I suppose that's from an aged care perspective. From a public sector perspective, there's, again, different mechanisms there, and ensuring that the, I suppose, local population that they're responsible for is being reached, and that they're meeting their needs. So that would be from reviewing what are the actual needs and have we met them? Are there waiting lists? There's lots of metrics within oral health that we use to indicate performance. Some of them crude, but I think we can utilise those that are already existing within these different levels of service to indicate performance on oral health.
Dr. Matthews, could I turn then to you and ask you whether you'd like to respond to those matters that Ms. Storman has just raised?
Yeah, so I think that I think she's raised some really valid points, and I think that the mandated, having a mandated accreditation around oral health outcomes and systems and processes within a facility is a really key part to that. And I would wonder whether a model of care if a model of care could be developed that utilised funding similarly to to the CDBS could be developed. I think that it's really key to think about supporting the aged care facilities to deliver oral care. So obviously some funding around that would be an important part of it as well. I suppose I got a little distracted about delivering care in the home before when we talked about, outreach models and those sorts of things. And so I kind of skipped over thinking about residential aged care. So I really support what Nicole has talked about there, that, that there needs to be some funding for and embedding within a residential aged care facility of the oral care cycle and process and practitioner. Yeah.
And with Ms. Storman's evidence regarding issues around equity of access and making sure that it's not those that are proactive that get the benefit of such a treatment model, such as an equivalent child dental benefit scheme. How do you address that in your community? You've described the relationship that you've got with a private practice in Wagga.
Yeah.
Are there systemic matters that you address to tackle those?
Yes. Yeah, so I suppose that the way the care gets escalated, for want of a better word, might be an oral health therapist might have had a conversation with the patient or the family, discuss the sort of symptoms, signs and symptoms, and then we kind of negotiate what's called a voucher, for want of a better word, and the voucher has a limited numbers of services that are available. And then we would also perhaps send an oral health therapist out to that person too. That sometimes occurs. So I suppose what happens is we record the treatment or the information that's gathered within our health system, and we can audit that, and we can look at claiming patterns that are aberrant or whatever. I think that the nice thing is working in a smaller community, I suppose you tend to, have a degree of comfort about the familiarity you have with the people that you're working with and those sorts of things. So I don't profess to be a health service manager to some degree. I do present. I think that what Nicole spoke about in terms of the metrics and the outcomes and measuring things. That's an important part, of having the system monitored and actually assessing if it's delivering the outcomes that we want, which is the improved health, oral health for older Australians.
If I might intervene there, there's a kind of sorry story that runs through the witness statements for the hearing this week, amongst other sorry stories, and it is that even where funding is provided for allied health services purposes, often what happens is that the residential care facility finds the cheapest option or doesn't provide at all, and that the system as a whole lacks accountability. So that's part of what's behind the questioning that you're getting. So I'd like to explore that issue, but I'd also like to explore the partnerships at the local level which actually make this stuff work on the ground, right? Dr. Matthews, we heard about your partnership with the MPSs multipurpose services, and they're run by the states and the Commonwealth jointly, so they're public sector ventures as opposed to not-for-profit and private sector. Is there engagement at either of your association levels with aged care providers nationally, or the department nationally, or even at the local level with services more generally? So what I'm trying to do is find out the governance arrangements that are currently there or not there.
Yeah, I'll speak a little bit first, if that's okay, Nicole. So at a local level with myself, we are working in partnership with the aged care aged care directorate, or whatever it is. I'm sorry, the words are escaping me, for the Murrumbidgee Local Health District. And so we work with, we have a overarching governance structure that, because we've entered into a partnership with them around some of the, because of the geography of where we are, we're able to access some extra Commonwealth funding because there's no dentist in the smaller towns, so we access a little bit of funding to help buy equipment, and then we utilise and then we made a business case for employing an extra oral health therapist to deliver the service. So that's been a lovely governance pathway for us. I think you raised a really good point, because I am uncertain how to get it to the next level within the Wagga community, where we have the not-for-profit sector. But what has been slowly building is some traction via the outreach that we've delivered sporadically with Dr. Mark Witherspoon and our oral health therapist locally. But it's inherent on the patients or the patients' families picking up the phone and ringing. It's not sort of delivered by the aged care centre, and I think that's a shame, because we're there and we're ready and we're hoping to get in the door. That's part of it. And then I think your bigger question at a federal level, I think that for me, and I'm a grassroots person, I'm not I don't see all of the global picture. I can't see how you have these two models of these two ways things get funded, and there's not a lot of talking happening in between. Is probably how I look at it. And I think, oh golly, these older Australians have paid taxes all of their lives, and now we're arguing about who's going to provide the services, which seems to me it's not putting the patient and that older person who has now transitioned to perhaps some sort of supported living in their own home or within a facility, not putting them at the centre of the conversation. And that's really key for me as a practitioner. Doing things for and with my patients is how I view my role in life. Yeah, so I think it would be lovely if there was some way of making that happen. Commissioner Briggs, yeah.
I can respond to that. And so from a local perspective, or even an individual practitioner perspective, I think we're commenting perhaps on, and correct me if I've interpreted this wrong, but the connectedness between all of this. And again, tale of woes, sad to say that dentistry hasn't had that connectedness. Doesn't mean that we don't want it. So from an individual practitioner perspective, I think we do it very well. So if we think of an oral health therapist who might be going into a residential aged care facility, it is within their duty of care to the patient, under the code of conduct, under the rules that govern us as practitioners, to ensure that we're not operating on our own. So that means that if I'm within that facility and I'm treating that patient as an oral health therapist, I identify unmet need that I cannot meet. It is my duty and my obligation to ensure that something is done about that. I can't just, that would be negligent if I didn't do anything about that. So as an individual practitioner, I am trained to go, where do I now need to seek care? And so if we're operating in these models that we're toying with and thinking, are they going to work? I would then need to go, well, where would this person seek further oral health care? And is that going to be contacting the local public sector practice, or perhaps that patient may not want to seek public oral health care? And I've seen that happen before, where they go, actually, I've had a dentist that has been treating me for the last 50 years. I would like to see that dentist, and I have an established relationship. So I've just identified an issue early on for that patient, being the practitioner on the ground, and referred them to their usual treatment-driven care, which would be their local dentist, if it is in a private sector as well. So that would still occur, and that's probably, I've seen that happen successfully before, but again, that is the minority of what occurs within facilities. So from an individual practitioner perspective, there would be connectedness between these two models just naturally with the way that we do operate. As you start to escalate up into the higher level of governance between the models, perhaps they don't communicate well to each other. Do they need to communicate well to each other? Perhaps not at a higher level, but I think from a funding perspective, so whoever's paying for it, they would want to know, and that's where those reporting outcomes would speak to whether they're happening. And I do think that you would be able to, all the way up from a higher level down to an individual patient level, you would be able to connect to see whether the two models are communicating with each other. So from, say, a unique identifier perspective, from a patient perspective, if they've received a referral from one model and that's documented, you would be able to see whether they then received some kind of treatment within the other model. So I think just the metrics behind them would naturally communicate and where they escalate to. Even though at a higher level they're two different things, naturally just down on the grassroots they are connected.
Thank you.
Ms. Stallman, picking up on what you just raised and ensuring connectedness of the oral health therapist on the ground at the residential aged care facility or in the person's home, how is the oral health therapist able to be a part of the broader care team, to be able to work with the personal care worker that either is attending upon the older person several days a week or is there on staff at the residential aged care facility?
Yes, if you look into the nuances of some of the evidence-based models, so there are a couple out there, but from the Australian context, it's been branded Senior Smiles. From those particular models, an oral health therapist is not there every day. So it's actually our role to ensure that the personal care workers and the nurses are skilled, but also confident to employ those skills. And there's numerous studies out there that say that nurses and personal care workers just think the mouth is gross. Because look, if you're not trained to look in the mouth, it is very intimidating and it's not very nice, especially if it's neglected. It's not nice. So the idea is that we would support the other members of the facility that are providing care to ensure that when we're not there, that oral health is supported daily. because naturally oral health is linked to so many other things. Eating, for example, if we're not looking at that. And the personal care workers would notice, if, say, for example, the resident was not eating, they would perhaps consult with the nurse and the dietitian to make adjustments. We do the same thing from an oral health perspective.
And Ms. Solomon, do you consider that there is a need to do that in a way where the oral health therapist is embedded, or are they non-embedded mechanisms that you think are worthy of exploring?
Non-embedded mechanisms. No, just to put it simply, no. I don't. I think in some cases it would work, and I don't have confidence that everyone who needs care would be able to access it, and that the other members of the team would continue to feel supported. Because when you think about it on a local level, the person that you work with, you know them. You start to understand what their profession is. You start to understand what their role is and what your role is to do with their role. So I think just the natural camaraderie and the working relationships that you get with other professionals working in a multidisciplinary team, which we stress is just so important across all facets of health. That's what makes it work. And then choosing to go in the non-embedded route, I just fear that we would miss out on all that, as we have done before.
Dr. Matthews, would you like to respond to that question?
Yeah. I think Nicole raises some really good points there. I think I will just talk a little bit about our experience in delivering initially education to personal care workers and starting this program a few years ago, and how it evolved. And I think one of our big learnings as a small local group was that when we took a intraoral camera into the facility and we took a photo within one of their residents' mouth, and we displayed it next to the textbook and showed them, this is what we're talking about in this education system, in this education module, is what's happening in your patient's mouth. That was really linking theory and practice for all the personal care workers. So that was a really key part of that information or that knowledge transfer. So I think that, and what we've recently discovered with the world and COVID is that we've started some teledentistry, for want of a better word. I'm just popping out the original words today, everybody. So we've actually asked patients to take selfies of their teeth, for want of a better word, and show us their problem, and then work out whether we're asking them to drive a couple of hours in to see us, particularly if in the COVID times, because there were some restrictions around dental practice. And so now as a local service, we're thinking about exactly what Nicole's saying, being part of the team, visiting, being there in person, but then perhaps if something's happening in between visits on our circuit, how would we get that information to us quickly? And so I think that there are probably some technologies, and with support we could train nurses and personal care assistants to perhaps take the selfies, for want of a better word, to deliver that information. I think Nicole will agree oral health practitioners are quite visual creatures, and so we like a good picture, and so they're the sorts of things that I think could be employed in accessing assessment. Absolutely, it's not going to access prevention and it's not going to access treatment, but in accessing timely assessment, I think that there's probably some more creativity we could apply in this space.
And I can see you nodding there, Ms. Storm.
Yes, I think maybe dentistry has resisted technology for a while, but we were forced to over the last 4 months. And I agree that in assessments and maybe referral pathways, technology can definitely be implemented better. And even thinking back to our discussion earlier around the initial assessments that's done on elderly people, even within the community, that can improve access to care for sure. And also in regional areas where perhaps they're not accessing care. So that's from an assessment perspective, I definitely agree. I think if it's connected to an oral health practitioner, someone who's trained to look at oral health, then for sure technology, I think, being used on the ground by personal care workers and nurses and GPs, when linked appropriately to us, can be very advantageous.
And efficient. Oh, sorry.
Oh, pardon me. Please go ahead, Dr. Matthews.
Sorry, I was just going to say, and efficient. The thing I really enjoy working with oral health therapists about is the information gathering that they can deliver for me, and their insights. I think that is really key. My staff do talk about cloning me, which is actually impossible. They want me to be in 5 places at once. But so when I have some really skilled oral health therapists delivering the information and checking in with me which way things need to go, it's fabulous. I actually see how I've escalated, uplifted my ability to direct people the right way, in partnership with the oral health professional, the oral health therapist. Yeah.
And would you like to respond, Ms. Norman, on your reflections of the relationship that Dr. Matthews has described between dentists and oral health practitioners?
Yeah, it's embedded within our profession. We love to work that way. We're trained to work that way. As I said before, I can't do all facets of oral health. Arguably, no dental practitioner can do all aspects of dental care. We always have to work within teams. And naturally, when oral health does escalate, you need treatment, you need more complex thinking, and that's where dentists are trained. And that's why, Dr. Matthews saying she wants to be cloned. It's because, she's taking care of a lot of patients and her time is better spent with the more complex issues. And working with oral health therapists allows her to be able to reach more patients and address the complex care that they might have while we're on the ground doing all the things that she's discussed. So, yeah, that's core to dental teams.
Commissioners, that concludes the questions I have for these witnesses.
Thank you, Ms. Hill. Commissioner Briggs, any further questions from? Thank you. Ms. Storman, Dr. Matthews, thank you very, very much for all of your input. I know that it's taken a lot of time, not just the hour here, but the preparation of the written materials beforehand. It has been very, very helpful to our staff and to our deliberations. Thank you both very, very much indeed. I should formally excuse you from further attendance, and I think we now need to have a very short 5-minute break so that we can have make a telephone connection for the next witness.
Thank you.
Temporarily adjourned.
Thank you for the
Thank you for the
opportunity.
opportunity.
The Royal Commission is temporarily adjourned. The Royal Commission is now in session.
It's fine.
Good morning, Beryl. Erin Hill here. How are you going?
I'm okay, thank you.
We've just started the hearing,
Yes,
and I'm going to ask the Commission's Associate to now administer the oath.
okay.
Mrs. Hawkins,
Yes,
do you swear by Almighty God that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say, I do.
I do.
Thank you.
Commissioners, Mrs. Beryl Hawkins is the next witness who has just been sworn. She is giving evidence by telephone to the Commission this morning. Mrs. Hawkins, I'll start asking you questions now.
Yes.
Could I ask you to please tell the Commissioners your full name?
Beryl Emily Hawkins,
And how old are you, Mrs. Hawkins?
91.
And we're speaking to you today on the phone from your home,
Yes,
and that's in Sydney, as I understand it.
yes, at Narrowena.
And you're there today with your carer, Tracy, as well.
Yes,
As part of the Royal Commission's work, you've prepared a written statement, haven't you?
yes.
And you've got a copy of that statement there in front of you,
Yes, yes, I have.
and it's 5 pages,
Yes,
and it's dated the 3rd of April 2020.
yes.
Were there any changes you wanted to make to that statement?
No, not really, no.
And the contents of that statement, are they true and correct?
They are.
Commissioner, I tender the statement of Beryl Hawkins dated 3 April 2020.
Yes, it will be Exhibit 17-12.
Mrs. Hawkins, I'd like to start the questions today by asking you a bit about yourself.
Yes,
And to do so, you provided the Royal Commission with some photos that you'd like to share with the Commissioners.
yes.
And you've got those in front of you there in
I've got
Narrowena.
them. Yes,
I'll start with the first photo that you provided us, photo 1. And what we've got up on our screens at the moment is a black and white photo with the title Beryl and Nobby, and that's from 1946, November 2. Would you like to describe that photo to the Commissioners?
that was taken during the war, and it was, a wartime picture. And we got married because my husband had to go away. And we were a very happy couple. Very young couple, actually, 18 and 20. Sorry.
And your husband's there, Nobby.
Yes,
And then if we look at that second photo, which is a photo of, is that Nobby with your young son there?
yes, my son Ken, yeah. That was taken at a wedding when my son was, very young. But he has since died at 31, and that's the only photo actually I've got of both of them together, so I hope that was okay.
And that's why you decided that you'd like to put that photo in front of the Commissioners this morning?
Yes, yeah.
The next photo, the third photo, is a photograph of you and your 2 granddaughters. Could I ask you to describe that photo to the Commissioners, please?
Well, that's my son's daughters, and they were babies when he died, and that's Joanne and Karen.
And how did you come to... I'll ask that question again, Beryl. You've indicated that your son died when he was young, when he was only 31, and his daughters were babies when he passed away.
Yes.
And he had been living in Australia at that time, but you and Nobby and Ken were originally from the UK, is that right?
Yes, that's right, yeah.
And how did you come to be in Australia then?
Well, we happened to be here on holiday when my son, he was 25 and he had his first major heart attack. When he came out of intensive care, he asked us if we would come out here to live, which I work for an airline and I could have come out once a year, but to come out here to help the family when he died, he knew, somehow he seemed to know he wasn't going to be here very long. And so we came out here because we loved him so much, obviously. Mum and I, and my mum, she was 80-odd, bless her, she gave up everything, and we gave up everything we loved in England, actually. But we came, and we've done it, and we were quite pleased that we did it. I love Australia.
Could I ask you then to look at that fourth photo that you've provided us? And we've got a picture here of you holding what's a very impressive certificate, from what I can gather. Could you describe that?
Well, I had worked for 24 years, and I got the award for it, for working 24 years voluntary, and that was the Sydney Prime Minister, Matt. Yeah, he was the mayor. Sorry, the chair. I couldn't think of the name. He was the mayor. Yeah.
And what sort of volunteer?
Sorry. Yeah.
You go, Beryl.
That was a very special time, actually.
What was it about?
Yeah, sorry.
No, you proceed.
It was about, I just felt that you get an award, but you don't really do the voluntary work to get an award. You get an awful lot of satisfaction out of helping people in different ways. So, yes, it was nice anyway.
And what sort of volunteer work had you done over that 24-year period, Mrs. Hawkins?
Oh gosh, I did 5 years with mentally and physically handicapped children. I worked with street kids for 5 years after my husband died, and I did drug and alcohol course for 2 years with the street, because of the street kids being on drugs, and to understand them. And I did a lot of other jobs. I can't remember what I did now. Oh, I worked for 10 years at the Compassionate Friends, because when I lost my husband, I didn't really get a lot of help because I hadn't been here that long with people. And I went to Compassionate Friends. They helped me. But in my going with them, I started doing voluntary work for 10 years, going to the city 3 times a week, talking to other mothers who'd lost children, and also being on the telephone for people to call me if anything happened, when anything happened to their children. So that was a very rewarding time, I feel. And I did a course of voluntary work with some of the children. It was a course that they did in the schools about drugs and everything. So it was quite a lot of different things I have done, but got an award for helping to start Interchange. I managed to get $50,000 to start Interchange for them, and it's been going as a big organisation since. So that was another thing, looking after children in their home, really disabled children, for their mums to get a break. That's all I can remember now about everything I did.
Thank you, Mrs. Hawkins. Now, I've already asked you to tell the commissioners your age, so I trust that asking for the final photo to be put up, which is a picture of you standing in front of a 90th birthday cake, doesn't cause you embarrassment.
Yeah.
Would you care to describe why you wanted to put that photo in front of the commissioners?
Yes, that's okay, yeah.
And what do you remember of that occasion, Mrs. Hawkins?
It was a very happy day because my grandchildren all came with their children, and it was just a beautiful sunny day, and it was just perfect because I don't see them very often, and it was nice to sit around the table to see them all together. So that was really lovely, yeah. Doesn't happen very often, but that was nice.
Mrs. Hawkins, I'd now like to ask you some questions about the aged care services that you receive.
Yeah.
Could you tell the commissioners where you're living at the moment?
Sorry, where I'm living,
Yeah.
in Narrowena, New South Wales.
And do you live by yourself or with others?
No, I live on my own.
And how long have you lived where you're currently living for?
14 years.
And what sort of aged care services do you receive in the course of your days? And
Well, I have 3 carers that come in, and because I'm able to keep my home nice and clean and look after myself. I want to keep doing that, because if I don't do that, the carers have got to do it for me, and I won't get outside the front door for a lovely walk or whatever I have to do with my legs, because they're not very good at all. My legs are getting very weak now, and so I really appreciate, and they're such lovely girls, and Tracy especially, she's a special girl for me.
And you're living in a unit at the moment that's provided by, and you've been there for the past 14 years, you've said, and that's a unit that's provided by the Ministry of Housing?
Yes, yes.
And
we were, but the Ministry of Housing sold them to Bridge Housing recently, so I'm not sure why they did that, but yeah, it's still kind of a housing situation.
And before you were in your current unit, where were you living?
I lived in a housing commission unit again, and I lived with drug addicts, alcoholics, mentally sick people, so many problems, illness with cancer, dear God, dying of cancer next to me, and nobody have any, they don't have any families, these people, to look after them when they're suffering. And it just seems awful to think there are so many people who are in housing commission that haven't got families or friends. Even where I live here now, there's a poor dear man dying, but he hasn't got any friends, or he doesn't want friends actually. So it's very difficult, but I found it hard because the drug dealers, they were dealing with drugs as well as taking them, and it was very frightening. And I thought there's so many places now with the housing commission, there are elderly people in their units now frightened to go out the front door because they've got ice users, and they're frightened because they get threatened by them. And it is scary. I was scared when the drug people come in the middle of the night and wanted to know where the dealer was. And in the morning there were needles everywhere in the grounds. So it's a terrible experience when you're old to have, and I just hope they can change that.
What is it about your current unit and where you're living that makes you happy to be living there, Mrs. Hawkins?
Well, I like living in my unit, but I'm not very keen on living where I'm living at the moment, because 10 people of the original people that came in to live in the units at the same time, 10 of them died, and now we've got, unfortunately, I'm not racist, but we've got 5 different nationalities that can't speak English, so there's no way I can go out and have a chat to anybody. So it's kind of changed this last few years.
Mrs. Hawkins, can I ask you to have a look at the statement that you've got in front of you?
Yeah.
And if I could ask you to turn to the second page.
Yeah.
And do you see there the heading that says mental health?
Yes.
That's the part of your statement in which you've described to the commissioners your experience with mental health as an older person, isn't it?
Yes.
And could I ask you to read to the commissioners paragraph 12 of your statement?
Yes, I can't go on buses anymore because I have weak legs. I can't go out by myself, and I can only go out when someone takes me. Sometimes if a carer takes me, I can go out for 2 hours, but 2 hours out of 24 isn't very much. It's very frustrating. My body is still willing, and I still look after myself, but I'm terrified of my future, of what's going to happen to me. I don't want to go into a nursing home. I see what is happening. in the nursing homes now. It's certainly frightening.
Could I ask you to read from paragraph 13 as well, please?
I absolutely dread my future because I'm frightened that I won't be able to get around. I don't want to have someone changing my pants. I don't want to be here for that. Do not want to have. Yeah, I don't want to be here for that. I haven't got any assets, so I can't pay 80,000 or 60,000 for a bed in a nursing home. I don't quite know what happens there, and that worries me.
Mrs. Hawkins, what issues do you experience with your mental health?
Well, loneliness, that was the main thing, because before I could have my package, my third, I couldn't get any help at all except for two hours a week. And I found that I was sitting here for hours not being able to talk to anybody, no phone calls don't get any more. And my doctor, who was very good really, she realised that how lonely I was, and she put me into my psychologist, and I've been coming to her, and actually she's helped me a lot over the years, and I was very depressed, but she managed well. I feel so much happy now that I've got the 3 girls and I can go out much easier now. So I'm hoping that I can still have more help in the home as I get frailer, because I think it's my legs that are going to let me down, and that worries me a lot.
Mrs. Hawkins, you described that relationship that you have with your care workers, including or especially that relationship that you have with Tracy, as being a very special relationship for you. What is it that makes that relationship special?
Because we're very much alike. When I first had her, I said to her, I feel like I've known you forever, because we just got on so well, and we still do. She's very good to me.
On your statement at page 3, do you see the heading there that says issues with my teeth?
Yes.
That's the part of your statement where you spend some time describing to the commissioners the issues that you've had with your teeth, isn't it?
Yes.
Could I ask you to please read from paragraph 16?
Yes, I don't get to see the dentist often because it's very expensive. It's been quite a few years since I've seen the dentist for a checkup. I only go when problems arise. Last year I had to get some teeth removed at the public dental hospital, so I knew I needed dentures. I needed a set of bottom dentures and 2 teeth at the top. In mid-2019, when I asked the dentist at the public dental theatre about getting some dentures, they told me that there are 2 years waiting list for getting dentures made up at the hospital. Instead, the hospital gave me a $1,000 voucher to put towards the cost of the new set of dentures. I was told that the voucher would only be valid for one of the 4 public providers in the area, so I couldn't go to the private dentist I liked and saw before they made for me. It cost me $3,500. I live off the pension, so I had to use my funeral money, and that was my funeral money, but keep having to spread it. I also have to spend another $2,000 on an electric bed because I can't pull myself out of bed or get my walker around.
Thank you, Mrs. Hawkins. Mrs. Hawkins, why did you want to tell the commissioners about the experience that you've had with your teeth and getting dentures made?
Well, I'm aware that there are so many elderly people that can't afford dentures when they get old. And like me, I haven't been able to eat for nearly 2 years, eat any kind of food, because, and there was a gentleman who used to dip biscuits in his teeth for 3 years because he couldn't get help for dentures. And apparently when I asked if I could get them for my package, I was told we don't do teeth. But having teeth, not able to eat, it means an awful lot to you. You lose your appetite. You don't eat as you should eat. It's very hard, and I find that it's something that should be looked into. Hopefully, when we get the dentures from the hospital, they should be a lot cheaper than when you go to private denture, because I could have paid nearly $10,000 for top ones, which I haven't been able to get. I can't afford to do that kind of thing.
What would you like to see changed on that, based on the experience you've had with your teeth the past few years?
Well, I would like them to make it possible for elderly people to be able to afford to get dentures, or at least give them to us before 2 years in the hospitals, the denture hospitals. It's too long to wait. I said to them I might be dead in 2 years, so I had to go and pay for my teeth.
Mrs. Hawkins, you told me when we were doing the preparation for today's hearing that there was a question that you wanted me to ask you. And that question was, you wanted me to ask you, why are you fearful for the future?
Well, I'm fearful of the future because I feel that I'm not going to be able to walk one day and take care of myself in my home now. And I just think, well, where will I be able to get? I haven't got any assets, and I can't afford to pay $30,000 and $60,000 or whatever it is to go into nursing homes. So I just don't understand how I'm going to. Well, what will happen when I get really old and completely unable to look after myself? It really scares me.
What has the impact of the coronavirus had on your thinking about your experience as you age and your care needs increase?
Well, I've sort of become aware that what elderly people have gone through before the virus was exactly what people are going through, having not able to go out when they're shut in. And that's what elderly people are. They're shut in because they're not able to get care to get them out. And I was very, 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 very depressed and lonely. It's loneliness mostly. So I think that's something that's very important to be understood now, that hopefully maybe things could happen in the future. Maybe I thought maybe if young women who had children would come round and visit you, with the elderly people, and take them out for a walk to the park and that, just for an hour. It's not for too long. And there are many ways that people can come in and maybe read to you. That's some of the things I've been thinking, that maybe that they can help elderly people in their loneliness. But some poor elderly people are not able to reach out for that help. They're not always capable of being able to find the home care that they need, or whether they can get a home care. They're not always aware of it, because they haven't got families that care about them. Fortunately, I was able to do that. I had help. But there are people that can't get help when they need it, because they don't know how to. It's always very complicated, usually, to ask for help in different areas, forms to fill in, whatever.
How do you think that those people who need help to access aged care services could be supported?
I don't know, really. I don't know how. But to be quite honest, when I didn't see anybody and I was lonely, I didn't want to be here. And I know there's a lot of people, I've been told, my carers, that's usual. People, all we wait when we're old is to die if there's nothing in our lives. And that's how I felt before I had got my carers. Not being able to get out the front door. And there's a lot of people like that. And they haven't got, I don't know, there's not the, It's not known where they are either. It's in Housing Commission. I know a lot of them.
And have you been thinking about potential solutions to your home environment, where you live, and what type of accommodation you would like to consider as an option?
I just want to stay in my own home. I don't want to go anywhere else, actually. I don't. It's not possible, really. I suppose it'd have to be a nursing home if I could get in one. I don't know. I don't know that much anyway.
And in the event that you were needing to move from your own home, Mrs. Hawkins, are you aware of any different options to how nursing homes can accommodate older people?
No,
Different examples from overseas?
Well, I know in England when I was there for a holiday, I was very impressed by that they'd set up these little villages for elderly people, and they also had a caretaker, and the caretaker had everybody's front door key, and they got in every day, and they were able to see how they are and if they had any needs for the day, and just a friendly chat to say how you going today or whatever. And it seems to me something that is a need here for that with Housing Commission. You can't put elderly people with other families that have problems, mental problems. Exactly where I live, that really gave me the depression that I didn't realise, although I managed to cope with it because I had done a lot of work with homeless people in my volunteering days, and they have got nobody to go to. It seemed a lovely idea, and I think it was kind of run by the council of the areas. So that's just one thing I just thought could be very good to happen.
Mrs. Hawkins, I'm coming to the end of my questions for you. Can I ask you why it was important for you to tell the commissioners your story today?
Because I couldn't get help with the package. I was only on a 2, and apparently I hadn't got anything there to help me. I had my carers come in twice a week for a walk for a little while, but I needed more than that. You do need more than that, really. So I just feel that I waited 2 years for the package, and that's far too long. I mean, I couldn't get any help. I couldn't get the physiotherapist. I had one and I had to give it away, and I couldn't get my podiatrist. I couldn't get any help, actually, because I didn't have a package. And that's a 2-year wait after you've been assessed 3 times. And fortunately, I wrote my letter in desperation of doing it also because there are other people I know that was waiting. My dear neighbour next door was 96 and she got a package when she died. And she needed it where she was living in a bad way. So I just think that is things that should be looked into now, dear.
Mrs. Hawkins, you wrote that statement that you've read from today in early April, and we are talking today mid-July.
Yes.
How has it felt to share your story and your experiences with the commissioners this morning?
Well, I felt quite passionate about the fact that I couldn't get my package to help me, and there's so many elderly people who couldn't get their package, and they're still waiting. There's a lot of them that cannot even get a grade 2 one. So I felt very passionate about the problems that it just seems to be that elderly people are having to suffer when they're not getting the help that was promised by the government. I mean, I went to a member of the parliament and said, I want to come and see about the package, and he said, what is a package? And I thought, well, your government sent letters around to us. So it was just a passionate thing that I felt I had to do. I felt I wanted to do it actually.
And before we finish our conversation this morning, Mrs. Hawkins, are there other matters that you'd like to raise to the commissioners?
No, I don't think so. I think I've covered most of it really now. I just want you to know that my family do love me, but as life is now, they've got children, they've got to go to work full time, they've got school expenses. It's very hard for picked-up families now, and even though they want to help you, they just don't have the time because their demands of family demands so much about them. So that's what I feel I wanted to tell you, that they do love me, but they don't have time. And I understand that.
Thank you, Mrs. Hawkins. That's the end of the questions that I have for you. You'll now hear from Commissioner Briggs and Commissioner Pagoni.
Thank you, Ms. Hill. Commissioner Briggs, do you have some questions you'd like to raise?
Well, no, I haven't. I'm just thank you for trying to help us. It's wonderful the Prime Minister helping the aged care people now. We're getting in contact with the Royal Commission to do it, because I think it's something that has to be looked into. For the elderly people have got to be looked after more now and in the future.
Ms. Hawkins, this is Commissioner Pagoni speaking. Are you able to hear me okay?
Yes, thank you, yeah.
Thank you. I just wanted to thank you for making time available and for having put your experiences on paper for us, and for being available this morning to relay that. It's experiences like yours that are very important that get told. It's important the public knows about it. It's important the government knows about it. And of course, it's important for we as commissioners to know about it. So we are very, very grateful to you for having spoken about your experiences. No doubt there are many other people in your position. It really is, we are very grateful indeed that you have helped us in this way. So I'm sure that there are many people listening to what you've had to say, reading what you've written, and I hope we're all learning the lessons from that experience. So thank you very much indeed. So I think we now have a short adjournment till we can connect the next.
I believe the adjournment is through to midday, Commissioner.
Yes. So we'll now adjourn.
The Royal Commission is now adjourned until 12 noon. Royal Commission is now in session.
Mr. Knowles?
Thank you, Commissioner Gunny. I now call Professor Clive Wright and Dr. Martin Gilbert.
We seem to have a tick. Mr. Knowles, CFA, and I suspect might be adjourned momentarily.
Yes, thank you, Commissioner. I believe the affirmation is to be administered to each of the witnesses. Just the associate with our approach.
Professor,
I think we'd better adjourn until this can be fixed.
the Royal Commission is temporarily The Royal Commission is now in session.
Madam Associate?
Professor Wright, do you solemnly and sincerely declare and affirm that the evidence you shall hear will be the truth, the whole truth, and nothing but the truth? Please say, I do.
I do.
Dr. Dorland, do you solemnly and sincerely declare and affirm that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say, I do.
I do.
Dr. Dorland, Professor Wright, thank you for your patience there. Can I ask you, Dr. Dorland, to state your full name for the Royal Commission?
My name is Matt. Look, I'm getting a feedback delayed as I speak, which is going to be very hard to make a sentence. But I'll say I do in terms of the affirmation.
Perhaps we'll work on that, Dr. Dorland, while I ask Professor Wright if he can state his full name for the Royal Commission.
My full name is Frederick Allen Clive Wright.
Thank you, Professor Wright. And is the sound okay at your end?
Yes, it's fine. Thank you very much, Mr. Knowles.
Thank you. Dr. Dorland, is there any improvement on the sound now for you when you speak?
I'll check by speaking. Let me see if that's better. Yes, the delay is still there, but it's much smaller.
Well, Dr. Dorland, are you content to proceed for the moment? And if it becomes problematic, let us know.
So I'm happy to proceed. I don't know if the technical solution might be to mute me so that I can't hear me.
Well, I know the commissioners want to hear what you have to say today. Can I ask you, I don't think you answered my question earlier as to your full name. Can you state that for the Royal Commission?
My full name is Martin Bryn Dooland.
Thank you, Dr. Dorland. And if the feedback delay that you've referred to becomes problematic, please do interrupt and let me know.
I will.
Thank you. Now, Professor Wright, you have prepared a statement for the Royal Commission dated the 12th of March 2020. That has a document ID number of RCD.9999.0297.0001. You'll see the first page of your statement hopefully displayed on the screen before you. Do you have that there?
It's not on the screen, but I have it in hard copy in front of me.
Thank you. And you've also prepared a response to draft propositions that have been prepared by council assisting and others assisting the commissioners. And that is dated the 14th of April 2020 and has the document ID number RCD.9999.0321.0003. Do you have a copy of that there with you?
Yes, I do. Thank you, Mr. Knowles.
Thank you. And have you read those documents lately, Professor Wright?
Yes, I have.
Thank you. And I understand that there are some minor changes that you wish to make in your statement.
That is correct.
Sorry, can you tell the commissioners what those changes are?
They're rather minor. Under page 1, B, background, second line, it should read School of Dental Science. If you could insert the term dental in that second line. The next line down, it has Deputy Health. It should be Deputy Dean of the Faculty of Medicine, Dentistry and Health Sciences. I apologise for those senior moments.
Not at all, Professor Wright. And Were there other changes that you wish to make? I think in paragraph 9B on page 4 of your statement.
You are correct. Under halfway down, we're further appropriate preventive and treatment regimes for older persons, which complements the Seattle Care Pathway, have been clearly. There should be an LY on clear. Make it clearly set out.
Yes, thank you. And was there a further minor typographical matter of that nature in paragraph 10 on the following page, page 5?
You are correct. On the last line, it should read, receiving aged care services within. So it should be not with the community, but within the community.
Yes.
Thank
Were
you
there
very
any
much,
other?
Mr. Norton.
Not at all, Professor Wright. Were there any other matters that you wish to change, either in the statement or your response to the draft propositions, Professor Wright?
No, I am happy that that's a clear and accurate record.
Thank you. Can I ask you, are the contents of the statement and your response to the draft propositions true and correct to the best of your knowledge and belief? And are the opinions held and expressed in those documents opinions genuinely held by you based on your expertise?
Yes, they are.
Thank you. I seek to tender those documents to bundle, Commissioners.
Yes, the two documents shall be Exhibit 17-13.
Thank you. Can I turn to you, Dr. Dorland? You have prepared a statement for the Royal Commission dated the 13th of March 2020.
That's correct.
That is document RCD.9999.0313.0001. You have also prepared a response to the draft propositions. That document is dated the 7th of April 2020. It's a 2-page document.
Yes, that is correct. That is correct.
And have you read those documents lately, Dr. Dorland?
Yes, I have.
And are there any changes that you wish to make in those documents?
No, there are no changes I wish to make.
Thank you. Are the contents of the documents true and correct to the best of your knowledge and belief, and are the opinions expressed in them opinions genuinely held by you based on your expertise?
Yes, they are.
Thank you, Dr. Dorland. If those documents could be tendered as well, Commissioners.
Yes, those two documents will be Exhibit 17-14.
Now, I will proceed to ask questions if there is any difficulty for either of you in terms of the sound that is becoming a problem in terms of your ability to give evidence. Please don't hesitate to let us know. Professor Wright, you've set out your expertise and experience in the field of dental health in your statement at paragraphs 3 through to 7. It's extensive. For the time being, I just ask you, it's true, isn't it, that you have extensive experience as a dental academic and as Director of New South Wales Dental Services, and now you work at the Centre for Education and Research on Ageing at the University of Sydney?
That is correct.
Dr. Dorland, you also have extensive expertise and experience in the field of dental health, and that's set out in your statement. That is extensive experience in public sector dental services, and you have headed both South Australian and Victorian dental health services over a period of almost 25 years.
Yes, that is correct. I would make one minor modification. At the time of writing the evidence, I was adjunct associate professor through the University of Adelaide. I'm in the process of relinquishing that title. That may well have happened or will happen in the coming weeks.
Thank you, Dr. Dorland. And both of you have contributed to national forums on dental health.
That is correct, Mr. Knowles.
Yes, that is correct for me also.
Yes. Now, I wish to return in some detail in due course to the draft propositions and explore further matters that you've raised in your responses. But before I do, can I ask each of you, are there any other measures, whether instead of or in addition to the measures that are described in the draft propositions, that you consider would improve and maintain the oral and dental health of people receiving aged care? And can I start perhaps with you, Dr. Doolan?
I have one addition to the propositions. I believe that if consumers, family of the resident, family of the older person, were more specifically aware of what expectations they should have of the aged care sector in relation to oral health, that would assist in maintaining standards.
Yes. Professor Wright?
I've got nothing further or new to add to what I've already committed in those documents.
Thank you. So if I could turn to the first draft proposition D1, which goes to funding public dental services to provide outreach services to aged care recipients. And I might seek to bring the text of that proposition up on the screen for each of you. Hopefully that will come up. But while that is happening...
Which proposition did it say?
You have both broadly stated your agreement with the need for dedicated funding for public dental outreach services for aged care recipients in your statements and your responses. Yes, you're nodding, Professor Wright.
Yes, that's correct.
That is correct, yes.
Yes, thank you. Now, Professor Wright, you have experience yourself from working at Concord Repatriation General Hospital in an oral health care outreach service. Can you briefly explain that experience and the benefits that you perceived from it generally?
Well, we've certainly tried to outline in the documentation to you that we started off some 5 years ago with a small demonstration program with 3 aged care facilities that were linked into Concord Repatriation General Hospital Department of Geriatric Medicine. We had 3 volunteer organisations and we constructed a program that was built around a private-public partnership where the public sector provided the infrastructure, an oral health therapist, and training, documentation for the aged care facilities. Our oral health therapist did oral health assessments at the institutions, and then referred those that needed immediate dental care to a private practitioner whom we had been involved with and had all the correct documentation to provide care in that institution. In subsequent years, we built that into 18 aged care facilities, and in 2018, we assessed just over 1,200 residents in those 18 facilities. So we have learned over those 5 years a lot about how to provide outreach, portable dental services to especially those that are frail and vulnerable in aged care facilities. We have also been involved in activities related to community programs where our oral health therapists and dental hygienists participate with people with dementia and work with the geriatric team within our aged care facility in the wards as well.
Yes. Thank you, Professor Wright. You've referred a moment ago to provision of these services to frail and vulnerable older people who are receiving aged care, and in your statement you've drawn
Could you say that again? There was a little bit of interference there.
Yes, my apologies, Professor Wright. It's apparent at this end as well. You've drawn a distinction between, on the one hand, people who are frail and vulnerable receiving aged care, and on the other hand, people who are robust and independent.
That's correct, and I think there are different ways that we should manage those different groups, and that then was reflected within my comments on the funding arrangements.
Yes. Can
I
ask you this, Professor? Sorry, Professor, you go.
I was saying it's clear to me that those with disabilities that are mild or moderate cannot navigate their way quite often through the intricacies of negotiating oral health care, and they need to be managed separately from those who can work within a marketplace as general dentistry is provided, in terms of consent giving, in terms of balancing off what they require, what they need, and what options there are. So I've tried to link the frailty on one hand, the 30% of the older population, against the robust 70% who can manage within the dental marketplace as any person could.
Mr. Knowles, the audio is very bad. Dr. Doolan and Professor Wright, if we were to adjourn now, I wonder whether we've solved the problem. Professor Wright, would you just say something so that we can check whether we might have solved the problem?
Yes. How are things going at your end in Adelaide?
Well, if only we were in Adelaide. We're in Melbourne and things are going dreadfully.
Oh.
Dr. Doolan, could you say something just to check?
Yes, I'll see if the delay is still there. Yes, there is a short delay still operating. I wouldn't be able to speak across it though.
Well, the options are these. We can press on, but I don't think that's very sensible.
No.
So what I'm going to suggest is this. Would the two of you be available for us to resume at 1:45? 1:45.
What time is it? Could you say that time again, please?
1:45.
That's an Australian Eastern Standard Time.
I'm terribly sorry. Melbourne time. 1:45 Melbourne time.
Yes, I can do that.
Yes.
All right. We will therefore adjourn now until 1:45.
The Royal Commission is adjourned until 1:45 p.m. Royal Commission is now in session.
Yes, Mr. Knowles.
Thank you, Commissioners. Dr. Dorland, Professor Wright, thank you for your patience. I think just before we ended up, Professor Wright, I was asking you about the distinction you've drawn between, on the one hand, frail and vulnerable older people, and on the other, robust and independent older people. In that regard, do you think the way that Proposition D1, which I'm hopeful will be on the screen before you now, the way that that is actually cast does what draws that distinction that you've referred to, in that it goes to whether or not people are able to travel to receive public dental services?
I think, Mr. Knowles, the issue that I have, especially with those that are frail and vulnerable, there's only a proportion of them. And the DWA, the Dental Weighted Activity Unit, is actually based on a fee-for-service model. So it's based on items of service that are provided. And it would seem to me that for our really high risk and vulnerable older patients, we should have a more embracive funding arrangement, that it's not on items of service, but it's on care itself. So whether it's the initial examination and diagnostic care in a package, or whether it's a component of continuous oral hygiene, supervision and support over a period of time. When we have the service items themselves being used for reimbursement, I think it can lead to over-servicing, and it can lead to options that don't provide the best incentives for patient care. When it comes to looking at our robust, cognitively and physically non-impaired older people, then they can negotiate a lot better over what services they have and what they need. So that's what I was trying to do, Mr. Knowles, in distinguishing there.
Yes. And would that be the sort of distinction that you would rely upon in terms of eligibility for people to gain access to an outreach dental service of the kind proposed in Proposition D1?
Well, I think the eligibility is also dependent on the interaction between the Commonwealth and the state. Eligibility criteria for state public dental services are usually based on pension and benefits card, the Commonwealth Dental Health Card. As I said, in our nursing homes, we're looking at around 80% that were eligible under the public sector scheme. So there's a high proportion of those, clear majority, are clearly eligible for public sector care under this arrangement.
Yes. Thank you, Professor Wright. Dr. Dorland, what is proposed in Proposition D1 isn't restricted just to aged care recipients receiving residential aged care. It also goes to aged care recipients in the community if they're unable to travel to public dental services. Do you regard that as an appropriate coverage or scope for such an outreach service program?
The provision of dental care, dental treatment to community living older people, we're used to, and the states are used to, using the same eligibility criteria for access to public funding, that is the card-holding status. There are people living in their homes who can easily travel to normal dental practices, be they public or private, and I would envisage that process continuing. However, there are people, the frail elderly living in the community, who do need assistance. Getting to a general dental practice is not easy for them, and they, as in for people in residential aged care, need support for their oral hygiene maintenance in their home, but also treatment in the home. That is more difficult. The home setting for aged care, dental care, is far more complicated to manage than in residential aged care, but the structure is the same.
And just picking up on the point that you raised, what services can't be provided by an outreach service in a residential aged care facility? Accepting what you say about in the community, it might be even more restricted, but in a residential aged care facility, what services can't be provided?
There are not many, scarcely any services of the type that are needed most that can't be provided in a residential aged care setting. Ideally, larger residential aged care facilities would have dental treatment facilities, not dissimilar to a normal dental practice. But in the smaller residential aged care, the minimum standard of a clean, well-lit area with water and ability to bring portable equipment into, it enables dental providers to provide basic prevention, examination and early intervention dental care of the basic nature, which does the most good. The type of services that are more complicated are mostly inappropriate for people in residential aged care, especially the frail elderly.
Yes. Can I ask this? We have heard some evidence in relation to the use of telehealth for the purposes of outreach, dental outreach. Can you, Dr. Dorland, say anything about that yourself in terms of what can be provided by telehealth?
Yes. In the model I propose, the responsibility for the maintenance of oral health rests with the aged care sector, and the registered nurse will be doing regular assessments using a question-based assessment tool. Now, uncertainty will inevitably arise from time to time, and telehealth would be of a great assistance to the registered nurse, to the aged care workers, where that uncertainty arose in the screening/assessment process.
Yes.
The dentist, oral health provider, would be better able to make a judgment about whether a dental professional is needed or whether that is not the case.
Yes. And Dr. Dorland, just thinking about that sort of screening process, that preventive, that aspect of preventive care as well, you've heard what Professor Wright has to say about dental weighted activity units and the use of that particular mechanism for funding of this outreach service model proposed in Proposition D1. Can you say what your view is about the appropriateness of using dental weighted activity units in this type of model?
There is certainly agreement between Clive Wright and myself that the fee-for-service model has its shortcomings, especially in this setting. However, there are several reasons that I am supportive of its use. Alternative funding mechanisms, such as fee per capita, I've had experience with in children, and I found that quite unsatisfactory. It has led to consistent under-servicing when I've been exposed to that. Other models, such as input funding, just give a fee and say, look after this person, I find unresponsive to evaluation. And paying by oral health outcomes, I've not seen examples where that has worked. The Dwyer approach to funding, which is essentially, as Professor Wright said, is essentially related to fee per item of care, has the advantage that the private dental profession, which will inevitably provide major proportions of this care, has that built into their funding systems. They're familiar with it, and will be more acceptable, and we have greater success, I believe, in attracting providers to provide care in the aged care sector using a funding system they're familiar with. It is certainly true that private dentists, when they provide care under a fee-for-service related model, do provide more care per person than public sector dentists who are funded on an input basis. In my experience, that is an inevitable part of the system. It is not extreme. It can be managed by careful evaluation of the service mix being provided by providers, and that provider given feedback about their service mix compared with best practice in this setting. And I think, therefore, it would be more acceptable to the dentist profession and make a scheme such as proposed in D1 more sustainable in a long-term basis with a cooperative and satisfied dental profession.
I want to come back to you in a moment, Professor Wright, but Dr. Doolan, so do I understand you to say that the DIWA would be appropriate for the services that are provided by the outreach service, but that would, beyond that, there are preventative measures that are difficult to assess by way of a fee-for-service model or other sort of care and treatment that is required for people living in residential aged care that is not accommodated by that model. Do you say that that would be dealt with through Proposition D4, that is funding provided to aged care providers to embed oral health therapists and other dental therapists and oral hygienists?
I would argue that the weaknesses of the fee-for-service type of funding in the aged care setting, it can be more difficult to fund preventive activities by that process, preventive activities by a dental provider, but it's not impossible. It just has weaknesses. The bigger problem, I think, is that the DWA type funding model has to effectively represent the real cost to a private dental provider of leaving their practice and seeing a variable number of patients in a residential aged care or even home setting. You can imagine that if a dentist left their practice to see one patient, the overhead on top of whatever fee they might get for the dentistry they do would be quite large per patient. If they had a range of patients to see, leaving their practice with a suitable fee level for the care they provide can be economical for them. That cost of leaving the practice could be funded by either an elevated fee per item, or it could be funded by a block figure representing that cost of leaving the practice with an item normal fee structure for the actual dentistry.
Yes.
Now, the relationship with the support for the aged care sector from oral health therapists and dental therapists, that is hard to manage on a simple DWA basis, and that, in a sense, what looks like non-productive time is actually productive in a preventive sense. That could be handled in the same way as the block payment for leaving your practice and going to an aged care setting. So there is a judgment to be made about how you fund those two on-costs to the clinical aspect of dentistry, either through a loading on the fee per item or a block funding recognition of the non-clinical nature of some of the services and the cost of leaving your practice.
Professor Wright, can I turn to you? We've heard evidence from Associate Professor Janet Wallace about the Senior Smiles program, which is a program of this nature of embedding oral health therapists into residential aged care. Can I ask for your views about that, given that you have been involved in an outreach program where the oral health therapists were not embedded in the aged care facility but were provided by the outreach services, I understand it?
That is correct.
Yes. Can I ask you, do you have a view about the respective models of that I've described? Can you Can you say whether you have a view about which one or what are the respective disadvantages and advantages of each of them?
I certainly think there are. The use of an appropriately trained workforce with the right skills and support is extremely important. Our oral health therapists are well trained to deal with and in aged care facilities and with older people. And certainly, as Dr. Doolan referred to before, there are tests, and we use the same sort of tests to assess oral health as nurses and some medical practitioners use. It's called the OHAT test, the Oral Health Assessment Tool. And that's the best device that oral health therapists and dental hygienists can use to screen all residents or all potential older people who may have oral health problems. Following that screening by an oral health therapist or a dental hygienist, then a referral process is engaged. So the referral process then allows for either public sector or private sector dentists to become involved. The oral health therapist, whether embedded within an institution or on a part-time salaried basis or a visiting basis, still provides the coordination and the focus of professional care. So I don't think to distinguish between whether an oral health therapist, dental hygienist is embedded in an institution or has a part-time role or has some clear relationship. And my preferred option is to have a relationship with the broader health community. One of the things that I've tried to argue strongly in my submission has been the integration of oral health into the general health and aged care system. That to me is paramount. Care is more important to me than the costs are. I appreciate that we've got to be sensible about costs, but we can't put cost reduction ahead of good quality care.
And Professor Wright, you will have seen and referred to the draft proposition from the Canberra hearing, I think proposition CH7, that refers to a multidisciplinary outreach service. And are you suggesting that there should be a dental component to a service of that kind? Is that what you're alluding to?
Absolutely correct. Absolutely correct. I think it is essential, especially as I've argued, in those that are frail and vulnerable, and that portion of the elderly population that's been judged professionally to be in a high-risk category.
Dr. Doolan, can I ask for your views about that, whether you think that the outreach service for dental services should be something that is separate, or should it be part of something larger along the lines of what Professor Wright has just said?
My view is that, and it's based on the research we did in the nursing home environment here in South Australia, is that the integration of oral health into the wider health and well-being of the patient takes place at the residential aged care facility. The registered nurse, for instance, when they develop their care plan, the care plan is not a dental care plan, it is a care plan for the residents' full needs. And that as part of that care plan, there is an oral health component to that care plan. When the screening process using the oral health assessment tool by the registered nurse or the general practitioner where available, where that identifies a need, the registered nurse, aged care sector worker, contacts a provider willing to provide that care, selected maybe by the family, but often just the registered nurse is aware of who is available and willing to come to the setting, and that an authority then becomes issued by the public dental sector for that treatment to be paid for under such a scheme as suggested in D1. So I would argue that the primary integration takes place by having the aged care sector take full responsibility for the full range of oral and general health issues. Now, where there is complexity, the aged care sector would need to perhaps bring the medical and dental components together at times, but the primary integration is right there at the beginning in the aged care sector. So that means the dental component is still dental and oral health focused,
Yes.
but brought in as needed by the wider health planning that takes place.
Thank you, Dr. Dorland. Dr. Dorland, you've said in your statement that you consider that aged care staff can be trained to undertake oral health assessments using oral health assessment tools. You've referred to that as not being in any way something that is just the purview of oral health therapists. We have heard evidence today and yesterday that even after staff have had sufficient training in that regard, and once an embedded oral health therapist has actually left an aged care facility and comes back after a couple of years, they've noticed deterioration in the standard of oral health for residents. How would you see that being resolved? Is there a need for a more regular presence or a greater presence of oral health therapists in residential aged care?
My view on this topic is that the oral health assessment tool assessment undertaken by the registered nurse is a screening tool, but it is not the base of prevention. Obviously the cleaning undertaken by the care workers will be part of that plan, but also that plan will need to include regular dental checkups by dental health professionals. So the oral health therapist or dentist will need to be brought in for a preventive checkup and the management of early disease that would not be disclosed by the oral health assessment tool. That oral health assessment tool is a screening tool to identify needs that arise unexpectedly in between that regular dental checkup.
And is that part of the outreach model in your view, or is it something that residential aged care providers would be separate, or aged care providers are funded for to obtain as part of their responsibilities more generally for aged care recipients' health and wellbeing?
Look, with the current level of awareness and interest in oral health in the aged care sector, I would be uncomfortable with the funding being allocated at this stage to the aged care sector. I have been warned by people who work in that sector that funding may end up somewhere else. So I would be arguing that the dental funding would rest, depending on the funding model adopted by in the future, the funding would, if it was a national partnership agreement with the states, the funding would rest with the state government, and when dental treatment was needed, checkups or whatever, the nursing home would contact the public dental sector and gain the authority for that care to take place. The alternative funding model for such a program is Medicare-like in its style, similar to the Child Dental Benefits Schedule. In that model, the funding would be with the Commonwealth, and simply, as for general medical practice, where there is need for dental care or dental checkups, that could be simply accessed by the provider, public or private, billing the Commonwealth.
Professor Wright, can I ask for your views on this particular topic in terms of funding for those types of activities that you would typically expect to be part of what occurs closer to the residential aged care service itself?
Yes. I guess the concern that I would have is that we've got to see older people as being extremely diverse, that they're not all the same. I've made a division between those that are frail and vulnerable and those that are robust. I think if a 75-year-old turns up for a general medical examination, part of that should be an oral health assessment. And there are mechanisms that could be built into the Medicare arrangement there for an oral health assessment to be provided within that framework. But when we're looking at those that are within aged care facilities, the diversity is also on ethnic background, not only on disability, and on a whole series of other personal, social, and behavioural issues. So we have nursing homes that are largely Korean-speaking, Italian-speaking, and not English-speaking. So when we're dealing with people with those particular issues in that diversity of hospitals, of aged care facilities, then you need to have diversity in funding. And I don't believe that one funding system will suit all activities. And I think as Martin pointed out, that if you are putting a package together, which is a home care package for daily maintenance, or an oral health care plan that requires specific type of activities for that individual person to be conducted on a daily basis, together with routine monitoring of oral health on a 12-month, 6-month, or longer basis, then you can put that in the form of some form of capitation package or in direct funding through public sector involvement of your oral health therapists. So I think there are ways, but it's not a simple one size of funding fits all under these diverse arrangements.
Can I ask you this, Professor Wright? In terms of the aged care provider, and perhaps if we just focus on, for the moment, residential aged care, what is, in your mind, the proper extent or proper description of the extent of responsibility that the aged care provider has for residents' oral health? These people who are effectively within they're frail, they're vulnerable, and they're within the responsibility of the provider. What do you say in terms of the nature of that responsibility? What is it?
Well, I don't know if I'm directly answering your question, but what they have at Repatriation General Hospital is a committee which is based on geriatric medicine, and it brings in senior nurses and managers from aged care facilities. Now, within that context, a whole series of issues related to the health provision and health issues of aged care facilities are discussed. Many of these discussions also include funding. They include accountability arrangements. They include transfer of records arrangements between the facilities and the hospital. Now, part of that group in the discussions is a dental component. So we have an oral health therapist and we've had a dentist that's been associated with that group. So when it comes to planning, providing information, contact and communication, you've got those linkages. So to step back, what I've been very comfortable in working with has been that core medical service that has been linked into general aged care services, and that therefore includes a whole series.
Sorry, Professor Wright, it looks as though your screen is just
frozen, including dental health.
So we just missed the last thing you said, Professor Wright. The screen momentarily froze.
Oh, okay.
Just at the point when you said the word series, you were saying that then.
Oh, there's a series of groups, committees and networks that all work together, but they're brought together by geriatric medicine in our particular environment. And what I'm saying is that provides a very interactive relationship, so you can get referral pathways across for individuals. You can identify some of the real serious issues of relationship between oral health and general medical health and find pathways through it for individuals in need. So it's that sort of integration within the health system linked into the aged care that I think is very important. So responsibility lies with each organisation, and we have a policy and documentation that the public sector signs off on, the institution signs off on, and the dental provider signs off on. Here is my role within this community. The aged care facility provides support services. The oral health therapist provides the assessment and the referral linkages. The private and the public dentists come in and provide the necessary care. So we've all got individual responsibilities that we identify in our documentation.
Thank you, Professor Wright. Dr. Dorland, can I ask you what you would say is the responsibility?
To what Professor Wright said, I believe, given that we are talking about national, Australia-wide, large numbers of institutions, that it could become, if you try to organise that on a large scale, repeatedly, administratively quite complex. My view is that the integration of oral health into the medical issues and broader wellbeing issues of residents in the aged care setting is best handled, has to be handled, by the aged care sector itself, the registered nurse in charge, perhaps. It is their job to bring about the integration that Professor Wright was talking about, seeking the advice and receiving the dental advice and medical advice necessary to have effective care plans for their residents. And I believe that is administratively simpler. What the complexity there is that, but it exists in the treatment areas as well, is that there needs to be processes by which we are reassured that those care plans are appropriate, are being implemented, and the oral and medical outcomes are achieved. That quality assurance foundation for the aged care sector and oral health, general health, needs to be very strong. I think we've had evidence in South Australia recently in another sector where that checking process and quality assurance process hasn't been maintained. And it certainly isn't in place with oral health at present.
Would you like to see some sort of explicit, measurable requirement or indicator in respect of the provision of oral health services into aged care, Dr. Dorland?
It's essential if the program is going to be sustainable and effective. There needs to be standards specified.
What might indicator be, Dr. Dorland?
Well, for instance, let's start at the very basics. Is there a care plan that covers oral health as well? Are oral health assessment tools being undertaken? Are referrals to patients receiving their checkups and treatment? These all are measurable. One of the nice things about oral health, it's highly, highly measurable, the oral health outcomes as well as the treatment patterns. And so if we have a simple checking up of the undertaking of the oral health assessment, the care suitability of the care plans, the implementation of the care plans, the oral health outcomes, the treatment profiles, those things are not new territory for oral health. and could easily be implemented in the aged care sector, sometimes on an ongoing basis and sometimes on a sampling basis.
Professor Wright, can I ask you the same question about what sort of explicit measurable indicators you would like to see in terms of the provision of oral health services in aged care?
Yes, I certainly agree with what Martin has just said, but the two other things that I would add to that list, and I think they can be written into standards for aged care facilities, would be education sessions for their staff. There should be general routine education sessions in oral health because there's quite a high staff turnover. And certainly there should be annual oral health assessments for all residents, or made available to them for all residents. And I think the annual would be the standard, and this can be varied on what the individual assessment needs were.
Can I ask each of you just finally, and I know I asked a question along these lines towards the beginning, but we were experiencing some technical difficulties at that time. Professor Wright, is there anything else that you would like to say now to the commissioners about how you think improvements could be made to the provision of and access to oral and dental health services for aged care recipients?
I think the first thing to recognise is that oral health is a very small component of health and aged care, but it's a very important component, and that oral health is actually related to general health and to quality of life. So when you're considering putting together the package for older people in aged care facilities, the driving principle for me is the recognition of that small but essential component of general health and quality of life to include oral health components within it. Thank you.
Thank you, Professor Wright. Dr. Dorn?
Yes,
In response to that general question that I put?
I was listening to Clive's response, and I agree with it. The issue for me is reflecting on why the National Nursing Home Dental Plan of a few years ago withered on the vine, because we have to have the reasons for its failure addressed in any new program. First of all, the aged care sector hasn't been interested in oral health, and certainly education of the workforce is part of that, both initial and ongoing. The other issue is that is also true of the dental sector. The dental sector does need ongoing support and learning in the management of people in community and aged care, residential aged care settings, but also a reason that it hasn't been sustainable and effective programs in the past. It has to be recognised that funding is an issue. I have said in other settings that medical practitioners who do visit nursing homes tell me that they look in the mouth at their peril, because they might find something for which they have no referral pathway, and they tend to go blind in a sense and not look for oral health issues. There does need to be a referral pathway funded sufficiently to manage the conditions that will be found by regular assessment. The same is true of the aged care sector. Registered nurses caring for their clients may well do all the things we would wish them to do, but if there is no referral pathway at sufficient scale, it won't happen. It'll wither on the vine, and eventually that assessment process will fail because you're assessing and finding things you can't do anything about. The other aspect of this is that if we're training people to do these assessments, to integrate oral health into general medical conditions, we have to have other settings, other aspects of the program in place. Otherwise, it's almost dishonest to do the training. You have to be able to manage the problems you identify that need identifying, you need to have the funding to do that in the dental care aspect, but also in the aged care setting. The residential aged care staff we've interacted with over the years tell us that simple busyness of their environment means that things that they see as less important don't get done. And therefore, funding of the aged care sector that reflects the things that need doing has to be addressed.
Thank you, Dr. Dorland. Thank you, Professor Wright, and thank you for your patience earlier. Commissioners, I don't have any further questions for Professor Wright and Dr. Dorland.
Thank you. Commissioner Briggs, any question you want to ask? No, you're still on mute, Commissioner Briggs.
Okay, we think we fixed it. The echo's still here, but I'll talk more. It really flows from what Mr. Doolan just said. And it's a really simple question. Most people, in fact I would say all people who work in aged care would brush their teeth at least once a day. Why don't they appreciate that the people they care for might want to brush their teeth each day as well?
I can give something of an answer to that because we have been told by care workers what they feel about brushing residents' teeth, and they simply find it unpleasant and invasive and do not enjoy it at all, together with not appreciating the consequences of not doing so. So there's an education issue, but also a degree of recognition of the consequences of the revulsion many of them have for opening a mouth and brushing the teeth. They just simply don't like doing it with their current knowledge and understanding.
Yes, I'd certainly agree with that, Commissioner, and I think you're right. I think training, education, exposure, developing some skills and knowing what particular products to use and how to use them are essential, and that comes back to the knowledge and training issue.
Thank you.
Professor Wright and Dr. Doolan, thank you both very much for the work you've put into these responses and the background information. It's been very helpful to us in our inquiries. We thank you both very, very much. And again, I apologise for the difficulties that we had before the forced luncheon break. Thank you both.
Thank you.
Thank you.
My pleasure. Thank you very much, Mr. Knowles, Commissioners.
Thank you.
Commissioners, I call Dr. Stephanie Ward and Dr. Jennifer Hewitt.
Associates.
Dr. Ward, do you solemnly and sincerely declare and affirm that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say, I do.
I do.
Dr. Hewitt, do you solemnly and sincerely declare and affirm that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say, I do.
I do.
Dr. Ward, could I ask you to please state your full name?
Dr. Stephanie Allison Ward.
And you are a consultant geriatrician and you're based in Sydney?
I am, that is correct.
And you're giving evidence today in your capacity as a consultant geriatrician?
I am.
You prepared a statement for the Royal Commission?
I have prepared a statement.
And you've got a copy of that in front of you today?
I do.
And I'll ask for the operator to display document ID RCD stop 9999 stop 0000 stop 0001. And whilst that's been brought up on the screen, Dr. Ward, I'll ask you whether you can confirm that that statement was prepared by you in July this year.
I will confirm that I prepared a statement. Do I need to see it on the screen? May I check?
Do you see a statement there on the screen before you?
I cannot see it.
Just bear with us while we're trying to get the technology to behave. I'm optimistic, Dr. Ward, that you might be able to see it now.
I can see the statement, and that is the statement that I prepared in July of 2020.
And are there any changes you seek to make to that statement?
There are no changes I seek to make.
Are the contents of your statement true and correct?
They are true and correct.
I attend to the statement of Dr. Stephanie Ward.
Yes, that statement will be exhibit 17-15.
Dr. Hewitt, could I ask you to please state your full name?
Dr. Jennifer Ann Hewitt.
And I might just ask you to see if you can hold that microphone a bit closer.
Is that better?
Yes, thank you. And Dr. Hewitt, you're a physiotherapist?
I am.
And you hold a Master's in Health Science as well as a PhD from the University of Sydney?
I do.
And you're based in the Tweed Shire, which is in the Northern Rivers region of New South Wales?
That's correct.
You've also prepared a statement for the Royal Commission?
Yes.
And I'll ask the operator to bring up document ID RCD stop 9999 stop 0315 stop 0001. Do you have a copy of your statement, Dr. Hewitt, in front of you today?
I do.
And can you see your statement on the screen there before you as well?
Yes.
And were there any changes that you'd seek to make to your statement?
There is one change. I've since submitting that statement, I have changed my employment to, I was working 2 separate jobs part-time. I'm now working solely for the University Centre for Rural Health in Northern New South Wales.
Thank you. And having brought the attention of the Royal Commission to that change, is the content of your statement otherwise true and correct?
Yes, it is.
You've also, Dr. Hewitt, prepared a response to propositions that the Royal Commission has asked you to consider.
That's correct.
And do you have a copy of that document in front of you today?
I do.
And if I could ask the operator in our hearing room to please display document ID RCD stop 9999 stop 0327 stop 0001.
I can see it.
You can see that on the screen, and I'm just waiting for the response document to be brought up by our operator here.
Okay.
That is the response document. My apologies. Commissioners, I'd seek to tender both the statement of Dr. Hewitt and Dr. Hewitt's response to propositions as a bundle.
Yes, those 2 documents will be exhibit 17-16.
Dr. Hewitt, could you describe to the Commissioners how you came to have an aged care focus to your work as a physiotherapist?
Yes. I was practicing physiotherapy for around 20 years before going solely into the aged care sector. I had a mix of private practice and public health experience as both an employee and a proprietor of my own practice. And when I moved to the country area, I decided to take on a contract in a local aged care village. That was approximately 12 years ago now. I thought at the time that it was going to be just another chapter, But on that first day in my first job in residential care village, I just really fell in love with the cohort. I was drawn to the wisdom and stoicism and sense of humour. And I've really, ever since then, never had the desire to leave the sector. I've been working in aged care, either residential or community-based aged care since then.
Dr. Ward, what motivated your choice to specialise in geriatrics?
I was training and getting ready for my physician's exam in Melbourne, and I had a lot of rotations in general medicine and other internal medicine disciplines. And what I really liked about geriatric medicine is that we were expected to look at the whole patient and conduct a holistic assessment and try and address multiple issues. And that was really rewarding, because I often felt if I was addressing perhaps a patient's pneumonia or perhaps cardiac failure, perhaps I wasn't getting to the heart of the issue for the person that I was caring for. Perhaps I wasn't addressing cognitive issues, psychological issues, functional issues. I was very lucky to work with some very inspiring and dynamic geriatricians or trainees in geriatric medicine. And I've benefited from excellent training in geriatric medicine. I'm a graduate from the Victorian Geriatric Medicine Training Program. And my experiences in practicing geriatric medicine in both metropolitan Melbourne and now metropolitan Sydney have been of working alongside peers who are very dynamic, very patient-focused. And I've witnessed an increasing interest in people going into geriatric medicine. It's a very rewarding specialty. Working with older people is, as Dr. Hewitt mentioned, incredibly rewarding, and it's great to be empowered to be attempting to address multiple health issues. And another wonderful aspect of geriatric medicine is that it works best in a team setting. You need to work with other clinicians like Dr. Hewitt, physiotherapists, and an allied team, and that's a really great way of working.
Dr. Ward, how do you work best with allied health professionals, such as someone performing the physiotherapy role that Dr. Hewitt has described and other components of that allied health team?
So working within an allied health team or as part of a multidisciplinary team is very typical of training in geriatric medicine. Many of us train in a hospital setting, and we might be looking after acute inpatients or patients in a subacute setting. We might be participating in multidisciplinary clinics, such as memory clinics, falls clinics, continence or pain clinics. And working within a team very much typifies how you practice geriatric medicine, because you can tap into the expertise of other professionals to identify physical, psychological, functional, social issues and work together to come towards the best plan for a patient, engaging with the patient and their family. I also work in outreach to residential care settings. I've increasingly done that in the last year as part of my work here in Sydney. And I still love the opportunity, when that opportunity presents itself, to engage with allied health staff when I see residents in residential aged care. But it's very different to inpatient care. It's not often that I can connect in person with someone like Dr. Hewitt, and far less frequently that I'm able to connect with allied health practitioners from other backgrounds. Some facilities I visit actually do employ, say, a social worker or an occupational therapist, and I'm able to connect with those when I'm assessing a resident and making a plan. And it's fantastic. I'll get their perspective and I can get their input into making a management plan for a patient I see. But that's the exception. So when I want to interact with an allied health professional in a residential care setting, it's often via phone call, email, or indirectly, most often via electronic communication, notes, or email.
Dr. Hewitt, what's your experience of what works as best practice to be part of that multidisciplinary team that Dr. Ward's just given evidence about?
In a residential care setting, actually in a multidisciplinary team, there's similarities between residential care and community care. There needs to be focus on the needs of the person in front of you. So if somebody presents, whether they're a resident or a community dweller, with needs such as pain, continence issues, memory issues, etc., the ideal or the evidence-based treatment is to take each need that the person demonstrates and talk to them about what their priorities are, and then match that need to the correct allied health professional and work in a coordinated fashion or an integrated fashion with the medical team, including the geriatrician and the relevant members of the allied health profession for that person's needs. At the moment, it doesn't work that way. At the moment, we do it the opposite way, and we try to make the person in front of us fit into a funding stream or a funding mechanism. So we say, you're eligible for this X, Y, or Z funding package, or under ACFI, you're eligible for certain services, but we're trying to make them fit into that instead of making the services fit to the person's needs. It's backwards, in my opinion.
I can see you nodding your head there, Dr. Ward. Would you like to respond to what Dr. Hewitt's said further?
I agree that integrative plan making and assessment of needs is key. So absolutely, everyone's needs are different and they need to be really carefully assessed. And I like the idea of integrative practice, because my personal and professional experience has been when I'm able to have a chat with a colleague like Dr. Hewitt, perhaps in a formalised setting such as a case conference that we would do in a hospital setting, you're able to think of problem solving in a more holistic way, in a more lateral way as well. Perhaps a colleague like Dr. Hewitt or an occupational therapist may have thought of something I haven't, or perhaps I would have picked up on something that they haven't, or one of us will have an insight that the other won't, and we'll be able to make a better nuanced and more effective plan. I very much support that things need to be needs-based, and I'm aware that often our management plans that we make are pragmatic in that we are conscious of what's available and what funding is available, and that does put a constraint on us. And I think it is much better that we can tailor a patient's care to their needs.
I'll pose this question to both of you, but call on you, Dr. Ward, to respond first, if I may. We've asked both of you to consider the draft proposition A5 on allied health, which contemplates a split between funding split between infrequent and episodic care in the allied health services and frequent and ongoing. Those issues that both of you have touched on your evidence today, would you see a split between allied health care on the funding model that I've just described that you've seen in draft proposition A5 relieve those tensions that you've described?
I see that there is merit between dividing between ongoing allied health needs and episodic short-term allied health needs. To me, that does have merit. I note that of the types of allied health given in the proposition, social work hasn't been mentioned, and I would just advocate that I often see an episodic need for involvement of a social worker in a residential aged care setting. But I think that certainly has merit to separate between ongoing and episodic.
And do you think such a split would support a greater focus on maintaining the ability and the function of the older person?
Yes, I do.
Dr. Hewitt, if I could turn to you and ask you to consider your response to that question.
Thank you. I think, maintenance is something to celebrate for the oldest old, because I think when we're younger, we often think improvement is the only answer. But if you're in your very older age, you're the oldest of the old, being able to maintain function is really a common goal that we see, and that's been a difficult thing I'll talk in terms of residential aged care. That's been a difficult thing to attain. I think the idea that there are physiotherapists is a physiotherapist attending a residential aged care village naturally implies to most people that there would be some kind of reablement or exercise program or something as part of the practice, but that's actually not always the case. The way it's rolled out under ACFI at least is that it depends entirely really on the philosophy of the management of the aged care village as to how they'll utilise physiotherapist service. So more recently, exercise physiologists and occupational therapists have also been included under ACFI. But prior to that, it was physiotherapists alone. And we're only funded for pain management using electrical agents or massage, which were both treatments that were used back in the 1980s and before that, but they've been outdated since then. And so if you worked then in a village where physiotherapists were employed only to perform ACFI-funded treatments, you didn't get a chance for that reablement or maintenance programs. Really what you were there for was to apply the funded pain management interventions. I think that the proposed changes, therefore, in the document would make a real difference in terms of, as I said, celebrating maintenance of function and facilitating maintenance of function. That would make a real difference, I do think so. In terms of the episodic care, it's a bit similar. When people were, even now, when people are, for example, if they have a fall and fracture their hip, which is a pretty common thing to happen in the older age, after they've had the surgery, they're often sent back. If they live at home, they'll be given a rehabilitation pathway. But if they're going to a residential care village, they're often sent home quite a lot sooner without the rehabilitation opportunity in many cases, because there's a misguided idea that they'll get some when they get home to the residential care village. And as I said, that depends whether or not you live in a village that provides that sort of unfunded exercise rehabilitation type approach. So being able to use episodic funding for that type of situation, where there's been an acute illness or a sudden change, and get a person back to their pre-incident level would make a real difference to people, in my opinion.
Dr. Hewitt, do you have a view about whether a split between the infrequent and episodic and frequent and ongoing allied health services would play out differently in a home care or community care setting, or are they the same considerations to your mind?
It's a little bit different. There are the same considerations. People who live in the community do, at the moment, even under the current funding models, have increased opportunity for access to allied health. And it's not just physio, it's other allied health as well. However, it does still come down to what they'll be funded for. So that a person, for example, could be travelling along quite nicely in their own home, receiving some low-level Commonwealth Home Support Program type funding. And if they have a fall and they go into hospital, the provider of the CHSP will very often lose contact with what's going on while they become an inpatient. And then they'll be treated as an inpatient. They might then go to a rehabilitation centre and then come out on something like a transition package or transition care package or short-term restorative care a little bit later on, if they've been out of hospital for a while. And these are all provided by different people with different different service providers. So there's a real lack of consistency. It's quite fragmented and difficult for that person, the client who's had, or the patient who's had all of these experiences to have that sort of streamlined, focused and seamless care delivery. So while they might be eligible for more opportunities for rehabilitation, it's still quite fragmented and it's not necessarily matched to the person's needs. It'll be matched to what the service provider that they're seeing is able to provide under the funding guidelines.
Dr. Hewitt, how could all those parties be brought in together?
I think it's integration is really the key to all of that. I believe that, so in a residential care setting at the moment, it's usually the registered nurse who does a full multidisciplinary sort of multifactorial assessment, let's say, not multidisciplinary, multifactorial assessment, and is able then to refer to whichever practitioners are coming into the village for an opinion. But that's probably going to be limited. It's unlikely that there'll be social workers, although, as Dr. Ward just said, sometimes you do strike it lucky with a village that has them. So that most of the disciplines are not represented in residential care. So I believe that in order for the residents of aged care to really get that integrated whole person care, we need to increase access to all of the disciplines in aged care, not just a couple. And those that are able to come in, those practitioners that are able to come into the village need to be given the ability to conduct a needs-based assessment and to prescribe evidence-based programs for the person sitting in front of them, rather than having a list of approved interventions that can be delivered.
Dr. Ward, pardon me, please proceed.
It's a bit different for community care, because in community care we do need, it would be ideal to have a multidisciplinary, I'm certainly interested to see what you think about this, Dr. Ward, but have a multidisciplinary, at least a case conference for people who are coming out of an acute episode back into the community, a needs-based assessment either in the hospital before they go, or through ACAT perhaps as soon as they come out, or through some sort of clinical commissioning model perhaps, where there's a multidisciplinary team, and really identify, get to the bottom of what that individual needs and develop an integrated person-centred treatment plan based on their needs.
Dr. Ward, could I call on you to respond to Dr. Hewitt's question and ask you this as part of that? Who should be conducting the assessment? What should the assessment process look like?
I'll respond in the first part to the transition from an acute setting to a community-based setting, which I've had some experience in. I've worked in the past as a geriatrician for a community transitional care program. I'm familiar with the program. I can see the merit of a multi-D program with geriatrician input and case management to oversee transitions of people from hospital with more complex needs back into the community. And I'm also aware that some hospitals run post-acute care services. So for a period of time, people can continue to receive physio, social work, nursing, occupational therapy engagement as they transition back home. And I will also speak honestly in that I hadn't considered the difficulties or the fragmentation between somebody perhaps going from a stable situation of being in receipt of aged care services, such as a community package level 3 or 4, coming into hospital and then having a separate treatment program, coming out of hospital with a bridging program, TCP or post-acute care, and then going back to the provider. I hadn't considered it from Dr. Hewitt's perspective that could be fragmented from a patient's point of view. But I'm also equally aware of possibly a more common scenario where somebody's healthcare needs and functional needs are different after an acute hospitalisation, and they may not already have a community package in place, aged care services in place, or they may not have aged care services in place to the level that they require. And so services such as transitional care programs in the community, or post-acute care programs or rehab in the home can help bridge to or to help improve people to a level of function where they can continue at home, and also help bridge to the receipt of community care services. For some people, they can be stranded because we are aware that there can be quite a wait for the higher level care packages in certain parts of Australia, the level 3 and level 4 packages. You might need to remind me of what else I need to respond to.
I'll turn to Dr. Hewitt and check with Dr. Hewitt that she's satisfied that she's had her query addressed.
Yes, thank you.
And I'll stay with you, Dr. Hewitt, and turn to the topic of referrals. Are general practitioners best placed to be referring aged care recipients to allied health services, in your view?
I think general practitioners have certainly already do refer for chronic disease management programs, for example. I think do you want me to respond to the idea around, excuse me, I'll just refer to the document. The primary care practice, is that where you're going?
Like to refer to,
yeah. I've been thinking about this a lot. I think that because I live in country New South Wales, so I do have a rural perspective as well. And what I could say is, I can see why you would propose this, but I think it's also worth considering that in country areas in particular, rural doctors are under the pump. There is already a problem with workforce capability to fit in, often in many country towns, to fit in as many consultations as they'd like to be able to help people. And I do have some concerns that if they then became the gatekeeper to access for rural dwelling, rural and remote even more, dwelling older Australians, that there could be a real hold-up with trying to progress referrals. I can say that not so long ago, one of our general practitioners here, I saw him later in the afternoon, and he was really exhausted. He'd fitted in 20-odd patients before I saw him. We had meetings to try and integrate some care, and then he was going on to be part of the primary health network conversations in the evening and something else later that night. And so I think resourcing that in rural, regional, remote Australia would be a challenge. The other concern, I guess, I've worked over the last 12 years, I have worked in about 20, it was 18 when I wrote my response, but about 20 different residential care villages now, because I've worked as a subcontractor where they bring you in for a few hours each week. But also I had 16 aged care villages in a randomised controlled trial that I ran. So I have had quite a lot of experience in seeing different ways that funding and is used. And I guess it would be, I could see the potential, and this is not referring to rural, regional, remote, this is just the potential, generally speaking, for some practices to end up using a lot of resources to develop the aged care plan, resources, costs that could have gone towards caring for the person or providing services, developing the aged care plan, and then I have seen, because this happens with service provision in residential care, there's often quite junior allied health professionals come on in staff, and so what then happens is that the referrals become in-house, and there's the potential for I would have to say, even though it's difficult to say this, there is the potential that the right services still won't be going to older people, that there would instead be incentives to sort of have a niche business around that model. And I think that's something that we need to consider, even though I find it really hard to say it. I have seen it in the residential care setting where in some cases there has been the gaming of the system, where physiotherapists, for example, have been brought in to bring funds into the village, but they use very junior physios and they burn them out very quickly, and there's a high staff turnover. And so I do think that's something that we need to just consider. And I wonder whether, I've been trying to think then, if that's the case, what would be a solution? I've been looking abroad as well. I noticed that in the UK they use a clinical commissioning model, which is a bit like, I know yesterday you spoke about the primary health network and the commissioning for mental health. That's something that we're trialling here, but that could be a possibility to consider, so that if a general practice either the general practitioners can't resource this idea, or that maybe primary health networks could be worth considering, because they are already multidisciplinary. They know the local needs of their areas. This would help in rural, regional, remote Australia, I think, because they know which allied health practitioners are there, where there's gaps, what they need to outsource, and so on. So I do think that's worthy of consideration. Probably needs a bit more discussion. I hope I didn't raise more questions than answers there.
No, I believe so that Commissioner Briggs wants to make a question.
Yes.
I believe you're still on mute, though, I'm afraid, Commissioner.
Okay, something came up on the screen which helped. I was going to make a great line about the McDonaldisation of the physio industry, but I'll move beyond that.
What was it? The what? I missed it. Sorry.
McDonaldisation.
Oh, the McDonaldisation.
I'm quite concerned by a thread that I've read about bringing in lowly qualified people, untrained, to work in that sector.
Yeah.
And I'd like to hear a little bit more about the UK commissioning model.
So my understanding, and I'm definitely not an expert in this, but my understanding is that each region then becomes responsible for the allocation of the health dollars, pounds, and the distribution. So as opposed to a capitated model, the income goes to the region, and they then they have positions where people will be conducting a needs-based assessment and then applying for use of the funds based on evidence-based outcome measures and recommendations for treatment based on what was assessed need for each person. So they control the bucket of money, sort of thing.
Yeah, that's what I thought you meant. So I was wondering, do either of you see that as a possibility in Australia?
I see it as a possibility. However, as I just said, I've really only been looking at it in response to the it's not my area of expertise. I would be very happy to connect you with health economists who would have a better idea about that. But I think it's worthy of consideration.
Thank you.
This is the first time I've heard about this, so I'm not really in a position to make more of an informed comment, but I agree that it sounds interesting and worthy of more consideration from what you've described, Dr. Hewitt.
I can see it helping. Sorry.
No, you go ahead.
I can see it helping in rural, regional, rural and remote Australia in particular, where there are different needs in different regions, and so it allows for that local flexibility.
Thank you. Ms. Hill?
Thank you, Commissioner. Dr. Ward, Dr. Hewitt has just given evidence in respect of draft proposition CH21, which is on the final page of the draft proposition of Allied Health that you've been provided. Have you taken the opportunity to consider that proposition, including that question which I posed to Dr. Hewitt, whether the general practitioner and a primary care model for aged care recipients that stems from the general practice would be an appropriate way to address the need for holistic assessment and holistic consideration of the older person's needs?
I have read the proposition. I have considered the proposition, and I've considered it from my experience point as a geriatrician, so I'm not a general practitioner, I don't work in general practice, but I work closely with general practitioners. So I can see that there is merit in a primary care doctor taking, or a primary care provider taking responsibility for an aged care plan. I think that anything that promotes continuity of care and some practice having accountability is a good idea, and that being centralised with a particular practice or provider, that has merit to me. I like that there is a suggestion that the care plan could be made in collaboration with a geriatrician. In practice, I'm not sure how that would bear out. I think that that works best if a geriatrician can actually meet with the resident and actually see the resident, as opposed to perhaps sign off on a sheet that's provided to a geriatrician. I am mindful of the workforce shortages in regional and rural Australia, and I think that there is scope to explore contact with specialists with telehealth, for example. We're all getting a bit of practice with that this year. In terms of the payment system to general practitioners, I would suggest that we must not disincentive. We must encourage primary providers, we must encourage general practitioners to work with residents in aged care facilities. My experience has been variable. I have worked in parts of metropolitan Melbourne where finding general practitioners to meet the needs of residents of aged care facilities has been difficult. I now work in a metropolitan Sydney setting where we're very lucky to have very committed, hardworking general practitioners who are quite well supported in a metropolitan setting, and we work with the general practitioners to provide that support. I think that it's really rewarding work, but it's hard work and it requires time. I'm be cautious about any change that would financially disincentivise general practitioners from taking on residents in aged care settings. So the level of capitation would need to be not less than what a general practitioner will be currently receiving from meeting the needs of residents in aged care settings. We don't want to lose general practitioners from that really key and important role.
Dr. Ward, drawing on the topic of telehealth which you've raised, and in particular yours and others' increased experience with video platforms to communicate in the past few months alone, do you see that there's a role for telehealth and like technologies in a reimagined system of allied health? And what would you need from telehealth, from a system which relied on telehealth-like technologies to be able to be supported in your role as a specialist?
I see that there is a role for telehealth. I've got some familiarity with it, and it can make assessments faster. And I can see that there can be a role for connecting with others as well. For example, I've never engaged in a case conference for a patient via telehealth, but how good would that be if I'd seen a patient in a resi care facility and I actually wanted to discuss the patient with the resident physio or with somebody who has been referred to as a private clinician, and we could tee up a time to just quickly discuss the issues. Because I often find an interaction with another practitioner can really identify additional issues you haven't thought of or solutions you haven't thought of. I think that's the beauty about working in an interdisciplinary or multidisciplinary team. What we need, we need technologies that actually reliably work. We're so advanced, but I think we've all had experiences where platforms don't work so well. And we also have experiences, and I have experiences at a facility end with, for example, poor Wi-Fi connections at a facility, or difficulties with staff accessing the platforms they need to, or different levels of familiarity with the technology. I think it's something we're all adjusting to, and I suspect that our abilities will improve. What we need is technology that works, support for that, support within facilities for that, so enabling good Wi-Fi, enabling staff to have access to the devices they need to have access to, which seems quite evident, but sometimes in practice this is what happens, and coordination around timing so that the right people can be together. But I think that would be fantastic. It's too infrequent that I get to interact with an allied health staff professional for a residential care patient, and when I am able to do that, I really think it helps the patient that I'm seeing.
Would you like to be able to refer patients of yours to an allied health professional through that MBS process?
I certainly identify the need for allied health when I see patients, sometimes, and I think that as long as that referral, and I can be confident that the referral is made, then I would be happy. If I need to rely on a general practitioner, I can see the merit of things going through somebody who is the person's regular doctor and who is across all of the issues. But I'm also conscious that that general practitioner is very busy, even in metropolitan settings, more so in a regional setting. And it could probably be more efficient if it's someone like a geriatrician, and there are increasing numbers of geriatricians that visit residents in aged care facilities, could also initiate a referral. I think optimally you would want the patient's general practitioner to be part of that plan, to understand what's happening, to know what's happening, because they're the person that's got ongoing care. But that's generally the way that I practice. If I'm going to make a big change to a resident's care plan, I would contact the general practitioner and make that plan with the general practitioner's awareness and buy-in. You optimally want that to happen. If a specialist can make that referral without engagement with a general practitioner, I guess there is that risk that perhaps if there's a capitation or a cap on the number of MBS items, that it could all be expended, and perhaps in a broader sense that it needed to be expended in different areas. So I guess that's just the consideration.
Commissioner Briggs?
Working in a multidisciplinary team is obviously something that is pretty important, and we need to see it becoming more common practice in aged care. How long do you think it takes to change culture, approaches and so on to introduce multidisciplinary care work in a sector like aged care, which has had less of it than I think we'd all like to see?
Well, I'll respond first of all, and I have seen that the model works in some aged care facilities, and so I think in certain instances there's an opportunity to learn from the facilities in which it is working within. There's that opportunity for inter-care provider learning. Culture change is always difficult, but aspiring to excellence and seeing models of care that have benefits throughout an organisation, I think is very powerful. I'd be interested in Dr. Hewitt's experience, because Dr. Hewitt has had more experience at the change management level at residential aged care, from my understanding.
Would you like me to respond?
Yes, please.
Yes. I think at the moment, as I mentioned earlier, I'm working for the University Centre for Rural Health, and we bring allied health students from multiple disciplines to our area in northern New South Wales for their clinical placements, for their rural clinical placements. And so it's not uncommon for us to have occupational therapy students, speech pathologists, physiotherapists, social workers, dietitians, and we have been forced, because of COVID, to conduct multidisciplinary case conferences via telehealth as well. I think the residential care villages that have taken us in as for the clinical placements have been really open to trying, because we're outside the funding model, we can bring those disciplines in that they currently can't have in their centres. And so we have been able to really put together some fantastic programs, and we've been welcomed with open arms. So I suspect, as you said then, Dr. Ward, it'd be picking the right facilities, but I think that there'd be many that would be open to testing how much benefit you could get from including a number of disciplines. I think the difficulty till now has been it's just hard to herd everybody into one space at one time. But that's one, I know COVID's been a global tragedy, but one thing it has forced us to do is what we're doing today. And we've really found over the last few months at the University Centre for Rural Health that we are collaborating a lot more with each other than we used to, and getting really great outcomes for the one person at the centre of all of our opinions. So I think it's certainly achievable.
Could I make one more comment on that? And I think that with any proposed change to a service model, it's really important to build evaluation into that, whether that be at the level of a rigorous randomised controlled trial or a simple evaluation. If we're going to promote changing the model at all, I think it's really important to be guided by what works and what doesn't. It's perhaps easy for us to conjecture about what might work, but sometimes when you introduce changes, and Dr. Hewitt will know about this as a researcher in the field, sometimes we expect something to work in science and it doesn't work, or it's not cost effective, and we want to be in a model where we are continuing to look at what works and what doesn't work. And on a side note, I see that, and this is a bit of a side note, but I do see that there's a role for research bodies like NHMRC and the MRFF to perhaps look at prioritising funding that is evaluating models of care that is aimed at improving outcomes for older adults living in residential aged care settings.
I think there's a real opportunity for leadership in these areas from young people with different eyes bringing change into the sector. And I'll leave it at that.
Dr. Hewitt, you've described being able to achieve really positive outcomes in only recent times with telehealth and a circumstance placed upon you by COVID-19 and restrictions in place around that. What have you been doing on the ground where you are, on the ground at the residential aged care facility, that has led to those outcomes? Who's involved? What does it take to get it right?
This is early days, of course, so I'm talking even this morning I was in Residential Care Village carrying my laptop with two students who were in Sydney. And they, for example, this morning they started with a falls prevention exercise program, which we connected up to the big screen TV. They had a allied health assistant as the person on the ground at the village who needed to know how to connect to Zoom, get everybody there in time for the class, and keep an eye on the ones that were the high falls risk. And then the class was run remotely by the students. We then went to see a number of people one-on-one where they were able to prescribe individualised needs-based interventions, where they'd spent some time chatting to the resident about what their priorities and goals were, matching it to their comorbidities and coming up with an individualised program. And what that required was, once again, somebody to hold the laptop, put it in the right place, make sure that the physio students could see what was going on, and stand alongside the resident if it was a high challenge balance exercise, for example, that they were doing to keep them safe. And so I could see the potential there for that type of model to really benefit people who live in residential care villages, for example, in a smaller town where there is no physio visiting the village, or OT or speech therapist. I mean, there'd be a number of, I'm talking physio because that's my area of expertise, but I can see that it would work to have a trained allied health assistant, for example, on the computer end, and the allied health professional guiding them. I can see the potential then to reduce the need for travel, the very real problem there is with equity of access to certain disciplines for remote. But even, I mean, if I think about in my own family situation, I have my mother, for example, will now, she's no longer able to drive because of a visual issue. So she lives in Sydney, but this would mean that physio could come to her too in her place as well. So I do think that there is a real scope for us to investigate that further and trial it. I think if I look at the model, and you mentioned, do you mind if I quickly just talk about the model using allied health assistance? Or?
Certainly, and I would ask you in responding, giving evidence on that topic, to consider whether in your interest around the role of the allied health assistant, whether they are an extension to the personal care workforce or a distinct part of the aged care workforce.
I think they could be both. I think personal care workers they certainly would need some additional training, but that probably isn't altogether difficult to put to work on those modules in addition to what they learn in their current training modules. Certainly, when I think of the trial, so I ran a randomised controlled trial looking at progressive resistance and balance training in residential aged care with a view to our primary aim was to measure falls and also physical performance. And to bring a bit of joy to the residents, there was what happened there was the model was built around a physiotherapist or exercise physiologist initially prescribing the exercise program at an individualised dose of how heavy the weight was, how often they had to do it, and so on. Then the gym program was actually manned or personed by volunteers or lifestyle crew or allied health assistants in the village. Didn't have to have the allied health, the physiotherapist there for every gym session. They were able then, the physiotherapist would come back once every 2 weeks and review and upgrade the exercises where necessary. But the sessions in the interim were carried out by trained staff that made the program much more cost effective. That worked really well in that setting, and I can't see why with the right training we couldn't use it for other types of interventions as well.
Commissioners, that concludes the questions I have for Dr. Hewitt and Dr. Hall.
Yes, thank you, Ms. Hill. Well, Dr. Ward and Dr. Hewitt, thank you both very much. You've put in a lot of time and effort into the information that you've given us, and thank you for making yourselves available this afternoon for the oral evidence and the questions. It's been very helpful indeed. Thank you very much.
Thank you very much for the opportunity.
I think I need now formally to excuse you from further attendance. Thank you.
Thank you.
Thank you.
Mr. Knowles.
Thank you, Commissioner. I now call Ms. Angeline Violi, Mr. Nick Young, and Ms. Lydia Conch.
Associate.
Ms. Violi, do you swear by Almighty God that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say, I do.
I do.
Mr. Young, do you swear by Almighty God that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say, I do.
I do.
Ms. Conchi, do you solemnly and sincerely declare and affirm that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say,
I do.
Ms.
Violi, Mr Young, Ms Conchi. Starting with you, Ms Violi, can I ask you to tell the Royal Commission your full name?
Angeline Elise Violi.
Thank you. And Mr Young?
Nicholas John Young.
Ms Conchi?
Lydia Conchi.
Thank you. Now, if I can return to you, Ms Conchi, you have prepared a statement dated the 29th of June 2020, RCD.9999.0345.001, as well as a supplementary statement dated the 12th of July 2020, RCD.9999.0365.001.
Yes.
And I think we have the first page of your initial statement displayed on the screen there for you to see.
Yes.
And I might try and bring up the first page of your supplementary statement alongside that as well. Ms Conchi, have you read your statement, your supplementary statement lately?
Yes, I have.
Thank you. And are there any changes that you wish to make to either of those documents?
No, there isn't.
Thank you. And are the contents of the documents true and correct to the best of your knowledge and belief, and the opinions expressed in them genuinely held by you based on your expertise?
Yes, they are.
Thank you. I seek to tender those two statements, Commissioners, as a bundle.
The two statements will be Exhibit 1717.
Thank you, Commissioner. Ms Violi, can I turn to you? You have also prepared a statement, RCD.9999.0344.001. Now, that statement on the first page bears the date 19 March 2020, but it's evident from the last page of the document that it was signed by you on the 28th of June 2020. Is that correct?
That is correct.
Thank you. And have you read your statement lately?
I have.
Yes. And are there any changes you wish to make to your statement?
There is only one comment in there where I mention that telehealth wasn't supported, and this was pre-COVID, where there are MBS items that now you could get a rebate with telehealth.
Yes, thank you. Subject to that change, are the contents of your statement true and correct to the best of your knowledge and belief, and the opinions in the statement genuinely held by you based on your expertise?
Yes, they are.
Thank you. I seek to tender the statement of Ms Violi, dated the 28th of June 2020.
That's Exhibit 17-18.
Thank you. Now, Mr Young, you have not prepared a statement as such in your name, but like Ms Violi, you appear on behalf of Concentric Health Care Services.
That's correct.
And have you read Ms Violi's statement lately?
Yes, I have.
And do you agree with its contents yourself?
Yes, I do.
Thank you. Can I ask you, Ms Violi, about your qualifications and experience? You're an accredited exercise physiologist and have been for the past 12 years?
That's correct.
Yes. And with Mr Young, you established Concentric in 2015?
That's correct.
And can you briefly describe for the Commissioners what Concentric does?
Yes, so Concentric Healthcare Services provides allied health services to residents in aged care, in residential aged care, older adults in the community, and also the general public in the community as well.
And what's your role at Concentric?
I'm the director and the COO.
Yes, thank you. And Mr Young, you're a qualified physiotherapist with over 10 years, or with 10 years of experience working in the for-profit sector, in, among other areas, the aged care area?
That's correct.
Yes, and what's your role at Concentric?
I'm the CEO of the organisation and generally drive business development.
Thank you. Ms. Conchi, can I turn to you? You're a qualified speech pathologist with over 22 years' experience.
Yes.
You're also the Managing Director of Avanti Care, which is also a multidisciplinary allied health services company. Is that right?
That's correct.
Yes. And you're also the Chair of the Board for the Society of St Hilarion, a not-for-profit organisation that operates 2 residential aged care services and community home care services in Adelaide.
That is correct.
And you also sit on an advisory committee to another aged care organisation in South Australia.
That is correct, yes.
Thank you. Ms. Conchi, you've said in your statement that Avanti Care supplies a full complement of multidisciplinary allied healthcare, education and training services to the aged care sector across both residential and home care settings. What specific services does the business provide? Does it operate out of a particular premises, or does it actually attend on people at their residences?
Yes. Firstly, can I say thank you for letting me contribute today? But in terms of our services, we deliver and we contract to other organisations. So we have a mobile workforce, and our allied health clinicians deliver their services on site within residential care premise or within individuals' homes that we are seeing within the community space. We are about to embark on a wellbeing hub in which we will be delivering on-site based services very shortly as well.
And in terms of the various allied health professionals that are engaged by Avanti Care, you mentioned earlier, I think you said how they were engaged. What is the actual process of getting the various disciplines of allied health care available to your business to then provide those services to others?
So there's a range of different ways. We either are contracted in on a contract basis and deliver a set amount of hours, particularly within the, space of occupational therapy and physiotherapy, in which we place manpower on the ground and they deliver those services that way. The other way we are engaged is we are just called on a call-out basis, particularly with regards to speech pathology and dietetic services. So they may not be necessarily on a contract basis. They may be more of a preferred provider type of method. We are also engaged by a community space, predominantly through brokering our services to a care provider who basically calls on us to provide services on a referral as needs basis.
And how do you engage the allied health professionals who are actually being provided to the aged care facility? How does Avanti Care engage those allied health professionals?
We employ all of our staff.
Employ all of them, right, I see. Mm-hmm. And in terms of the various allied health disciplines, do you employ psychologists or social workers or other allied mental health professionals?
No, we don't at this stage. There, we have been requested to on numerous occasions, but there isn't a funding opportunity, or there's not the funding to deliver those services and make it viable for us to bring it within the infrastructure of the business. So we've chosen not to date.
What do you mean by that when you say that there's not the funding that is available for that opportunity?
So within residential care, there isn't a specific, item that funds mental health workers, social workers or psychologists. So when we have been asked if we are in a position to offer psychology services, we have had to see if there was anyone available within our network that we could contract in, and that would come at quite a significant price. And when we've offered that to aged care providers who've asked that of us, they've refused it based on the fact that it would be a significant cost to them.
So, just on what you mentioned there, how does your funding, how do you get paid at Avanti Care? Where does your funding effectively come from? Your revenue come from?
a number of different streams. So our physiotherapy and occupational therapy services are remunerated through directly from the residential care provider. So we have a role in being able to claim and support the claims for within ACFI for high level needs, and then the funding that is generated from that will typically be used by the residential provider to then fund those physio and occupational therapy services on the ground. Speech pathology, dietetics tend to really be at the request of an organisation, and there isn't any direct funding that they can necessarily generate or in any way have any influence over the funding that's generated through ACFI. So that comes from the same Commonwealth funding that the residential care provider has, and they will pay us through that. And podiatry services are delivered and predominantly funded through the MBS chronic disease management scheme. And if there is an excess to that service, then the residential care provider that chooses to have those excess services will pay for those. That's within residential care space. Within the home care space, we're paid through the home care packages predominantly, or sometimes private or self-funded individuals, and they'll pay either through private health or as I say, through home care packages.
You as I said earlier, you've said that Avanti Care supplies a full complement of multidisciplinary allied health care. How do you establish a multidisciplinary service delivery the way that you've described it? You're engaged to provide one discipline in respect of one area with one funding stream. How does it work such that you're able to provide a multidisciplinary service to people where the disciplines are actually talking to one another about the actual care that needs to be provided to a particular person?
We've really just had to invest in developing the systems and processes that allow us within the organisation to be able to do that. Essentially, the organisations we work with will still be requesting of us that service, and we'll still go in and deliver that service in the way we would, whichever way they're funded. But then how we process those payments, how we invoice for them, how we are remunerated from them is then down to our processes to be able to generate those invoices and the remuneration for that, and we do that in conjunction with the provider. But essentially, I guess, am I answering the question that you're wanting?
Well, I'm asking you whether or not, when you're asked to provide a particular allied health service, whether it is just a single discipline of allied health care, or are you engaging in a broader process of looking at the person's general well-being more broadly and thinking about a plan which engages multiple disciplines of allied health services? Is that something that Avanti Care does in the way that it delivers its services, or is it more the case that you have an aged care provider might come to you and say, I want a physiotherapist, and that's what you do and that's where it ends?
I would say that it's a bit of both. We try to the best of our ability to drive that service, to frame the way that is, to be very holistic, to, for example, if we're in an organisation that uses all of our services, it's much easier as a multidisciplinary organisation to be able to have a very holistic approach and have everyone in the team involved in the care for that individual. It's more difficult when a residential provider or a home care provider only uses part of your service, because you're then having to communicate with potentially other providers. And we do that. We will collaborate with other providers where possible. It does make it a little more disjointed because it's more difficult to be across the whole service. We do also, though, however, it's down to the relationship and the communication you have with the provider. So if you have a very open, transparent communication, if you are very involved in your relationship with that provider, you're in a better position to essentially have a greater impact on their overall care and their overall care plan. And certainly those of our team that are based on the ground, like the physiotherapists and occupational therapists, they are much more a part of the team and able to do that. For those individuals that are coming and going on a more consultative call-out basis, it's a little bit more difficult to do. But as I say, as an all-in-one organisation, when we're all in the one space or with the one residential care provider, we communicate amongst each other to be able to share that
Yes.
care as well.
Thank you. Mr. Young, can I ask you to describe Concentric's business model?
Sure. Our business model is fairly unique in that we establish standalone clinics that are actually co-located within aged care facilities, and that allows us to provide services both to the general public within that space as well as services to the residential aged care facility. So it's a combined model that allows access to community and aged care facilities.
And in terms of the 4 core services that you provide, can you again very briefly just explain those and the funding, how they're delivered and the funding that sits behind them?
Yep. So we deliver pain management under the aged care funding instrument. We also deliver functional assessments on an as-required basis, which is paid by the aged care provider. We also deliver NDIS and community, so whether that be a home care package or funded via the NDIS. And then we also deliver private services, which is private paying in the community.
Yes. Can I ask you this, perhaps if I turn to you, Ms. Violi, does Concentric provide services in regional, rural and remote areas?
How far away would you consider that?
Yes.
No, we do, and look, it does. We definitely do, actually, especially in WA because it is so large.
Yes.
So,
and what is there? How do you manage that? Do you employ telehealth at times? Do you use allied health assistants? How does it work?
So in one in particular, because of the core services that we're delivering, there's a high amount of hours. We employ our practitioners down there. And because we create a hub or a location where we're able to then service the community, that just gives us extra hours, if you want to put it that way, extra scope to actually employ multidisciplinary allied health. If there is funding available via telehealth, so like with the NDIS, when they're with COVID, they've enabled funding via telehealth. Same with chronic disease management during this period of time, then we can deliver it via telehealth as well. But previous to that, that wasn't an option.
Yes. And what about allied health assistants? Do you engage them, or do you do your practitioners engage with them at the aged care facility?
Definitely, yeah. So a lot of the facilities that we work with actually have their own allied health assistants, and we work very closely with them. We actually consider them part of our team because we encourage that they participate in our continuing professional development and our education to ensure that what they're doing with residents is under the directive of the allied health professional.
Yes. And Ms. Conchi, if you're nodding, is that something that also exists at Avanti Care?
Yes, as I concur with Angeline in that there are some organisations that will employ allied health assistants, and so we work closely with them. On some of our sometimes we have models which are a hybrid model in which they will employ a physio or an OT and bring us in as a supplement, and we work together. And as with Angeline, we do the same. We bring them on board within our own professional development programs to just try and ensure we're all approaching the services with the same philosophy, and that's very much around ensuring that it's around wellbeing and delivering purpose to those residents.
Can I ask you, Ms. Conchi, whether does your business provide services, allied health care services for aged care recipients receiving respite care?
Yes, on occasion it is. When we are asked by the organisation, at times the organisation will fund that, and at times they will. The individual has been asked to fund that, but on either occasion we've been asked to come in and provide services, for respite residents, and we will do that. Yes.
When you say the service or the individual has to fund it, when is there funding available in a dedicated way for people in respite care for allied health services?
I believe that respite care have respite care funding. I don't I'm not aware of there being specific funding for the allied health component within that. So residential care providers that we've worked with over the years, we have been asked on occasion to provide the service. Either the residential care provider will choose to pay for that out of their pool of funding, or they will ask the individual, the resident or their family to contribute towards that because it's not within the ACFI model. And that's very dependent. I have my own, based on my own experiences, has been dependent on the values of the provider.
Yes, I see. And Ms. Violi, what's your experience in respect of respite care where people may be the difference between whether or not they move back to their home or move into residential aged care on a more permanent basis?
So in regards to respite care, I might just elaborate a little bit more on what Lydia was mentioning. They don't have ACFI funding like a permanent resident would, where pain management will be funded. Hence, you'd have your physios or your OTs coming in for that type of allied health. Normally with respite, you will have your basic functional assessment or your physio assessment, mobility chart done when they come in. What we offer with Concentric is an additional services model where the respite's actually out of their own pocket will pay for a rehabilitation package where they're actually receiving allied health intervention. What we're finding with that is generally respite, a lot of respite residents are using it as a try before you buy. They're coming into aged care because they're testing it to see if they like it, if they like that facility. Most of them want to go home, some of them can't go home. So if we are providing a service that they'll then be receiving when they are permanent, at least then it gives them a bit of an idea as to what to expect when they are a permanent resident, rather than just coming in and not receiving the same level of services as a permanent resident.
Can I ask each of you now a question about the fundamental reasons for allied health services being provided to people receiving aged care? And I put that there are two core reasons. One is just a regular, ongoing, day-to-day provision of services for preventative care and maintenance of functioning and independence. Perhaps as well as a long-term slow stream rehabilitation on the one hand, and then on the other hand, a more short-term rehabilitative reason for the provision of allied health services to recover from some particular episode or event that is adverse. Can I ask each of you to tell me whether you have a view about that sort of distinction between reasons for provision of allied health care? And perhaps if I start with you, Mr. Young.
I think it's really important that there is a clear distinction between the two, and also what will be decided for the slow stream long term versus the short term, what's actually going to be implemented. I think the other thing that's really important that I want to make a comment on is quantifying clinical changes during these both of these funding streams. So I think in the slow stream, what we've done, we've partnered with Macquarie University, and every 13 weeks we reassess objective markers that the residents are required to go through a battery of tests so we can determine exactly if they are improving with the slow stream ongoing physiotherapy or allied health. And that's good so that you cannot just go through the motions. So I think, first of all, I think it's a very good model in terms of having access to ongoing therapy, but I think it's really important that there are clearly identifiable clinical outcome measures that need to be done by that. I think the short-term rehab is also really important because quite often the clinical need for more intensive rehabilitation, for example, post-hip fracture, post-fall, if a resident comes into a home after discharge following a stroke or another neurological incident, then there needs to be clinically, most of the time, an intensive bout of therapy to really augment the slow stream. So I think both of those offerings are quite impactful, but my disclaimer would be that there needs to be clearly identified clinical outcome measures so that the system can't be gamed.
Yes. Can I ask you, Ms. Violi, for your view, at least at this stage, in terms of just that distinction? I will come to draft proposition A5 in due course, but just at a high level, that distinction in terms of the reasons why people need allied health care to maintain their well-being.
Yeah, definitely, especially as you get older, looking at older Australians, there is a need for ongoing therapy. And then if there were to be an incident, as what Nick mentioned, a change in their care needs, a substantial change, then there wouldn't necessarily need to be an acute episode of a higher amount of therapy, but multidisciplinary therapy approach at that point to get them to a certain level. So it should be based on outcome measures. And then once again, maintenance again, otherwise that you will see a further decline.
Yes, which is not to say, of course, that these two reasons for provision of allied healthcare services can't coexist for the one person at the same time. You may have an underlying need and then something that sits on top of that in terms of a particular adverse event.
Definitely.
Can I ask you for your views on that type of I guess you'd say, division of reasons why people need allied healthcare? Do you think it's a valid distinction?
I do, and I concur with both Nicholas and Angeline. I think that the clarity needs to be an understanding that longer, slower stream, ongoing maintenance type care or allied health care is really about maintaining function and capacity as individuals age, because as they age, it's the declining capacity that leads to them to become less mobile, less able to eat, and all those chronic health conditions will kick in. So having that ongoing, continual well-being focus, and I'd like to add for everybody within aged care. I think at the moment there's only pockets of individuals within residential care who can access a lot of those services based on whether they meet criteria. I believe anyone that is within residential care and home care should have access to that ongoing approach, because it's all about preventative care, preventing the decline and maintaining function. And ultimately, it's about ensuring that individuals who want to continue to be engaged in things that are meaningful for them and have purpose in their life need to have capacity to do so. So that longer term approach of allied health care is really all about ensuring that we can continue to see what is important and implement what is important to the individual as they age, and ensure that we maintain the function for them to engage in those meaningful activities for as long as possible. So that's one element. And then you've got obviously the short-term, more, I imagine, intensive rehab approach, I believe is definitely warranted post an acute event, following a fall, a stroke, or any kind of acute medical event that arises at some point, that allows for that intensive input, and as Angeline had said, in a multidisciplinary approach, which is really about rehabilitating back to the best possible function that someone can have to continue engaging in those purposeful and meaningful activities for them.
Yes. Ms. Violi, in terms of that day-to-day, regular, ongoing, preventative and maintenance-based allied health services delivery, who do you say should be chiefly responsible for that overall health and well-being of a person who's living in residential aged care?
Who is responsible for delivering the service, or who is responsible for organising the delivery of the service?
Well, who's responsible for that person's care?
If you're living in residential aged care, then the aged care provider is responsible because you are now living in their home. But
yes,
it needs to be a collaborative approach where it's not just the manager of the home or the care manager of the home or the RN that's looking after them, but also including the resident, their needs, their goals, their relatives, their allied health team, geriatrician. It should actually be a collaborative approach. And based on assessment, but it must include their goals. You know,
yes,
we can't force allied health or any other health or therapies on a resident or on a person.
Yes. Can I ask you, Mr. Young, for your views on that question that I've just asked Ms. Violi?
From a therapy perspective, I'm fairly confident in saying that a physiotherapist could lead the particularly from a functional capacity perspective, quite confident that they could lead a key therapist model in which the resident would be assessed, and then the required allied health needs could be ascertained from that assessment.
Ms. Conchi, do you have a view about this question of responsibility for a person's health and well-being when they're in residential aged care?
Yeah, so I'd like to clarify in saying that I think the residential care provider is most certainly responsible for their overall care, as they are providing the care needs and the accommodation for those individuals. Where I think I kind of move away from that is that I think that, and we're talking now about funding, and I don't know if I'm jumping ahead here, but in terms of funding the residential care provider to be responsible through the funding model, I think that's where the difficulties arise. And I think the allied, as Nicholas has said, I think the allied health provider is certainly definitely well equipped to drive and deliver to develop the framework and deliver the services that are best positioned for those individuals within residential care. I actually think they're better placed to do that than just the residential care provider. It's not the core service of a residential care provider to focus on wellbeing and restorative care approaches. It's what an allied health individual is trained to do. So I think, as Angelina said, very much around a collaborative approach, but I think the responsibility to their wellbeing should sit with the allied health provider, and then in collaborating, the overall care should sit with the residential care provider.
So how does the if the overall care sits with the residential aged care provider, and the I think you were saying that another aspect of a person's wellbeing might sit with a allied health provider, is there a prospect that there might be a dispute as to who's actually responsible for a person when they fall unwell between two?
I think if it's I think if the overall care sits with the residential care provider, I think they ultimately are responsible. I think the wellbeing outcomes and services that are delivered and the accountability to those outcomes are the responsibility of the allied health provider, and they can be accountable to the residential care provider within that framework. But in terms of driving the service and delivering those outcomes, I believe the allied health provider is best to do that.
While we're talking about funding, Ms. Conchi, you've said in your statement that the greatest challenge for older Australians in residential aged care accessing allied health services is the aged care funding instrument. Can I ask you to explain why you say that? And I know you have just gone into some detail in that in your statement, but just briefly, what are the key reasons why you regard that as being a challenge for older Australians in residential aged care accessing allied health?
Yeah, I'll explain that by saying that the Aged Care Funding Instrument, or ACFI, is extremely prescriptive in its nature and very restrictive. It has many barriers in place in terms of what can be delivered. So what is quite substantially funded is physiotherapy and occupational therapy services for complex pain management. But the sort of treatments that can be delivered for that specific funding are very prescriptive and are not evidence-based and do not focus on the well-being of the individual. If anything, I'd go so far as to say they actually it incentivises a decline, because we are not in a position to be able to actually embrace wellbeing approaches, restorative care approaches, exercise, movement, mindfulness, all the things that go to enhance a person's wellbeing are not funded. What is funded is only that very prescriptive small criteria of just massage and the electrotherapy techniques and TENS machines and those things that really don't actually benefit the individual in any way as they improve, as they age. I guess in addition to that, there's the fact that there's funding dedicated to those specific services, but there isn't any specific funding to the other aspects of a multidisciplinary allied health team, and that is speech pathology, dietitians and podiatry. To date, we can get podiatrists on the ground relatively easy by accessing the MBS schemes, the Chronic Disease Management Scheme, and that's allowed us to have residents to have great access to podiatry. But specifically to speech pathology and dietetics, it's quite limited. And I guess the negative to that is that, dietitians and speech pathologists are very much involved with preventing the pneumonias that can have someone decline very significantly, preventing weight loss that leads to lots of chronic comorbidities. They are very much a part of the team in terms of ensuring someone's health and well-being is maintained to be able to be engaged in all the physiotherapy exercises and occupational therapy programs and those sorts of things.
Yes, thank you, Ms. Conchi. Ms. Viola, you have a view in terms of what Ms. Conchi's just said?
Yes, I'd actually continue on and say that physiotherapy, occupational therapy, that's not funded technically. It's 20 minutes of somebody on the list, the allied health list that is stated. That could change from time to time, to go there and deliver whatever modality of treatment is stated for the duration of time and the frequency of time. It's not actually the allied health professional. They don't care that it's a physiotherapist doing it or an occupational therapist, because it's not actual physio or OT clinical treatment that's being delivered.
Yes. Mr. Young, is there anything you wish to add to what's been said by Ms. Conchi and Ms. Viola?
Yeah, I'll further Ms. Conchi's comments. It actually is an instrument which promotes disability, and the concept coming from the private sector and coming in and not being able to deliver evidence-based treatment based on a clinical need for that specific individual, as opposed to a one-size-fits-all approach in any other healthcare setting would be quite absurd. The idea that you can just deliver the same modality of treatment for every single diagnosis that exists within a population, it's quite absurd. So I think not only does it promote further disability, but it definitely does nothing to empower the resident or re-engage the resident's functional status.
Thank you. Can I turn now to the draft Proposition A5 that you have all seen and commented on, and this is at document RCD.9999.0343.0019 at 0020 to 0021. And that should come up on the screen shortly with bold text at the bottom of one page and a table at the top of the next page, which I think you've all seen. You've already given me your views, or given the Royal Commission, I should say, your views on this distinction between the kinds of allied health services that are contemplated in the two funding streams, you might say, or in the mechanism. And I think you agree that that's a useful distinction. I don't want to put words in your mouth, but I think that's you've all agreed that that distinction is worthwhile. Can I ask you this? What do you say, how do you say that one might categorise what services fall within one category and what services fall within the other? And can I ask you that question first, Ms. Viola?
Yes. So the best way to do this is actually assess the client, the resident or the client who's living at home, and determine what their needs are and what their goals are. Just having a list is just going to restrict what the services that they actually need will be completely restricted. If we have a look at what's written on there, you've got no psychology in frequent and ongoing. However, we know a lot of older adults who may have lost a partner now have to deal with change, going from their living at home independently to moving home into residential aged care, loss of function, loss of independence, isolation, depression. That should enable frequent and ongoing psychology or mental health of some sort, and that's not listed. Whereas, one big piece in here is that exercise physiology is off both the lists. whereas you're talking about a restorative exercise-based approach, restoring function or maintaining it as much as possible, yet you have an allied health professional whose job is to use exercise and to prescribe the right exercise to elicit certain responses in the body, and they're not on either list. They've already
take those lists, Ms. Violi, as illustrative examples and not meant to be in any way exhaustive, but in terms of the distinction, do you think there's a need for some degree of specificity about what falls in one camp and what falls in another? If it's left to an individual assessment, is there a problem that people will just make an assessment based on what it might be directed to a funding outcome, for instance, the assessment?
Well, no, it should be the assessment and then based on the clinical outcome that you'd want to be achieving.
Yeah.
And then you look at which services will enable that resident or that client to achieve that clinical outcome. And it should be a multidisciplinary approach because it most likely will be.
So who would make that assessment then?
Someone who is highly trained, whether it's an allied health professional is a good place to start, but then that person would also need to be trained. And I think it's the type of assessment that you're using, because if you just had an OT come out and do an OT-based assessment, then they're going to recommend OT therapy, like an occupational therapy. If you have a physio do the same thing, it's going to be a little bit more biased towards physio. But if you have an allied health professional who is using an assessment that actually has all different areas, a speech path area, dietetics area, and they indicate that therapy is needed, then at least they know that it's to refer on to that type of therapist. And that's a multidisciplinary assessment, not just one.
The concept of that multidisciplinary assessment, presumably the assessment would have to occur by somebody who is independent of the people who would be providing the services, or do you see that as not being necessary?
Look, not necessarily. We deliver services. I'm going to take this out of aged care because aged care services are pretty much directed due to the funding that's available. But if we look at NDIS, so people out there living with disabilities, we will go there and do an assessment, and we've trained our team that will have a key therapist out there to actually identify areas of need by other therapists. And if it's indicated that they do need speech pathology, they do need dietetics, they will then refer on and have that as an inclusion in their total therapy, not just in one area. So we are the service provider who's doing the assessment, but we're also delivering the services if we can. And if it's outside of our scope, we then assist them in finding the right provider for their services, because we're looking for a clinical outcome. That's the main goal, is to try and get them to reach a certain level of function.
Yes. Ms. Conchi, do you have a view about that in terms of this distinction and how you might decide what activities fall within one funding stream and what fall within the other?
I actually quite strongly support what Angeline has just said, particularly around goals. If we look at delivery of allied healthcare services and what our ultimate goal is, and that is to facilitate wellbeing in those individuals, a big focus for us, certainly in our team, is to always identify what that individual wants that's important to them. In the end, take it right back to basics. Why are we doing what we're doing? It's all good and well to ask someone to improve their arm movement, but if it doesn't achieve a goal for them, what's the point? It has to achieve a functional goal and a purposeful goal for the individual that we're supporting. So if we're assessing that individual and identifying with them that it's really important that they write letters to their family, then that may flag the fact that they have some hand dexterity issues and need some support with an OT to work on some techniques for that. Or if they identify they want to be able to learn how to use an iPad and have some visual problems, that might flag needing, say, some occupational therapy work or an optometry consult. It's about what is it that individual who's aging needs to ensure they're achieving meaningful engagement every day in their life. And I think for us as allied health professionals, our role is very much to facilitate and optimise the well-being to be able to do that. So going back to your question around the services, it's very much, as Angeline had said, identifying those services based on the assessment. And whether that is done by an allied health therapist or, as Angeline had said, someone who's well trained. I would even go so far as saying someone within a residential care setting or a home care setting who's well trained to identify those needs and flag the referrals from that would be appropriate for that role. We certainly work with home care providers who are not allied health clinicians who will identify the needs through an assessment with the client to determine whether they refer to us or not.
Is that somebody who might be a registered nurse or a nurse practitioner in this country?
I think it could be anyone. I think it's less about the profession and more about the ability to dig deep when determining goals, sitting down, doing an assessment and determining goals with the client. Someone who's a good communicator, someone who's trained well to identify that if an individual says, I've got pain here, or that should flag maybe a physio referral, or if an individual says, I'm having trouble, I cough when I eat, or that'll flag the need for a speech pathology assessment. So it's anyone who's had the training to look for the identifying signs, but also has the ability to communicate and really establish that rapport with an individual, someone they trust that they can open up about those issues with.
That trust issue that you referred to, I mean, would another candidate for that role be someone such as a general practitioner who is a regular health practitioner that the person sees?
Potentially, I think potentially, I probably would even suggest that what tends to happen now is these issues are often identified by a range of different people. It might be a nurse, it might be a GP. They then raise that to someone who is the coordinator that calls in the allied health professional to implement the service. So it could be that there's one person responsible for coordinating that, but essentially that alarm can get raised through a range of different professionals, certainly a GP, nurse, an allied health professional, a carer. Sometimes even those delivering food will notice someone, they'll notice someone in the home who'll say, I struggle to chew that food, can you provide me something softer? And they'll flag that up to the nurse, or they're having trouble chewing and eating, and that'll then get raised to the fact they need a speech pathology assessment. So sometimes that information is coming from a range of different areas. I think as long as one person is coordinating it, we should be working as a team, because that's when you're going to get the most holistic approach to what that individual needs.
Mr. Young, you haven't provided a statement. You've said you've adopted what's said by Ms. Violi in her statement. Can I ask you, though, for your comments on draft proposition A5?
I might just start by discussing that comment regarding the GP interaction. I think
yes.
GPs in particular don't have great understanding of what allied health practitioners do and the effect that they can have. I assisted Angeline in her response and quoted some research that was conducted by the University of Sydney. They do what's called a beach report on every couple of years, and something like less than 4% of knee osteoarthritis, which is a very common condition that will present in the geriatric population, was referred to allied health practitioners. So even though the research is quite clear that that is the best conservative approach for management of that condition. So I think just a slight comment on that is that those GPs, in theory, would be a great place to start for the overall care needs and coordination, but it requires significant upskilling when it comes to referral and what can be achieved by an allied health practitioner. With regards to the A5 proposition, my personal views are that for the ongoing, frequent and ongoing, I think one of the key parts of that is that it would be good to identify key clinical indicators that are linked to the ongoing clinical outcomes of those residents or participants. So walking speed, ability to perform a timed up and go, some clinical outcome measures that need to be maintained for that frequent ongoing therapy. It could be something from an OT perspective, could be something from a speech pathology perspective, but there might be a battery of clinical measures that can continue to be linked towards the health of those individuals that are either they're receiving it in their home or receiving it in the residential aged care facility. So I think my view on that is making sure that we're linking that on frequent and ongoing therapy to clear clinical markers. From an infrequent and episodic, particularly from an assessment perspective, it's quite simple from a therapist perspective to know when someone needs an infrequent or episodic intensive treatment package. If I have an acute condition that I know frequent slow stream is not going to impact, as a trained allied health professional, I should know quite quickly that this person needs 4 weeks of 3 sessions a week in order to really maximise the clinical need before transitioning them to the slow stream frequent and ongoing. So I think from an assessment perspective, allied health practitioners are highly trained, university trained. Granted, I probably wouldn't do it from a new grad or a 1 year out, but after 3 years of exposure to a clinical setting, you should know if someone needs an episodic and how intense that episodic treatment needs to be.
And do you have any other observations you would like to make about draft proposition A5?
The other observation would be, if we are going to say frequent ongoing equates to 1 a week over 52 weeks, there may be a mechanism by which those 1 a week could be condensed if needed to really augment the episodic, or if the episodic wasn't available for whatever reason. So I think my only comment is still allowing some flexibility to the delivery of the treatment in the frequent and ongoing, as opposed to fixing it to once a week.
Yes, I think those caps that you're referring to are in respect of the infrequent in terms of the Allied Health Service funding under the MBS, as I understand it. But maybe I thought
there was a potential example of, say, 1 a week for physiotherapy. I thought that was listed.
Yes.
I may be incorrect though.
Yes.
Yeah.
But in any event, you're saying there should be some flexibility about how
Correct.
those apply. I understand. Can I ask you, Ms. Violi, and then I'll come to you, Ms. Conchi, just for your final thoughts on proposition A5?
Yeah. So just a couple of I guess, concerns would be comparing this type of funding to the other streams of funding that as allied health professionals we're exposed to. So things like, how home care packages are funded and NDIS. They've got lots of positives, especially with NDIS where it's at a gazetted fee. So, and it's an industry average, which is a lot better than, if the funding for frequent and ongoing is going to the aged care provider, and I'm talking specifically for Resi Care here, which I even mentioned for home care, but if it's going to the aged care provider, then what incentive do they have to be going out and getting highly skilled practitioners? And is it going to be based on clinical outcomes? And are the allied health providers going to be put up against each other to see who's the cheapest? Do the allied health providers have to have Medicare provider numbers, or maybe there's a different fee for limited registration allied health providers compared to ones who have got their full registration with a Medicare provider number? So I think that it does need to be looked into a little bit more. Respite care is not included in there. That was another comment. Level 1 and 2, I know that's already mentioned, that needs to be considered anyway.
Can I ask you this about the first point you make about funding and if it went to the approved provider? Is that a question in your mind about accountability in terms of how any funding would be spent by an aged care provider? And if it is, could it be dealt with through other measures by auditing and accountability measures for the approved provider that apply to the approved provider?
And I don't mean to be sceptical here. However, if there were to be outcome measures, that's how they'll be accountable. Just be mindful of what type of assessment or who's doing the assessment, and can they be tweaked? It's sometimes, looking at ACFI, it's tick a box. Don't say anything more. Just do what ACFI wants you to do, and it will be fine. You'll get through that validation. So in regards to this, it can be very difficult from an allied health provider's perspective. Yeah, it's very difficult to have highly skilled practitioners to be giving them purposeful work and engagement in aged care, but then having to be reduced the rate that we deliver that service is reduced to whatever the lowest person out there can actually deliver, which is very, very difficult as a company to be able to manage that. So when you're looking at the accountability, that's where, like what Lydia mentioned before, maybe the accountability should actually be with the allied health provider. But in saying that, it would be good if the funding was available for the allied health provider directly, because if it's not going to the aged care provider, then there's no incentive for them to find the lowest fee that's out there. The incentive is for them to find the one who is most appropriately trained to get the best outcomes.
Thank you, Ms. Violi. Ms. Conchi, can I ask you for your thoughts, if you have any additional ones to those that have already been raised in respect to Proposition 05?
Really, just to expand on what Angeline has just said, I think I have quite strong views around whether the residential care provider is funded for the allied health services or whether the allied health provider is funded for those. And I base that on my numerous observations within our current experience where ACFI is funded directly to the residential care provider. Two examples I'd like to provide. One is that, as Angeline has explained, allied health providers are quite frequently having to tender for work based on cost. It becomes very much a cost-based transactional type service. So it's very hard to deliver a really high quality service when it is just constantly about trying to beat another organisation on cost. And I would suggest that there is almost a set fee that is industry obviously developed that we can all be able to not have to compete just on cost alone. The other issue around that is that by funding the third party, the residential care provider, it doesn't incentivise the quality, it doesn't incentivise the outcomes and goals, it incentivises the financial goals. And so what I mean by that, as well as, who can tender for the cheapest contract, there's also services such as, for example, speech pathology is an example I have, in which just as recently as this week, we were asked to change the sort of way we would deliver a service, in that we were asked to, and this has happened numerous times before, to not repeat or not review a resident that we know needs follow-up because it just incurs additional costs to the service provider. And so we're being asked to change what is within our duty of care and what is the best way to deliver a service so that we can ensure that person's getting the best service overall, purely based on the fact that it will cost more to the service provider. So going back to that comment, by funding the residential care provider, there's a third party who can maximise funds from that pool of funding. And so rather than it going directly to the allied health and be apportioned directly to the allied health service, you are having to therefore deliver that service within a pot of funds that the service is driven by that. As opposed to if it is directly delivered to the allied health professional or provider, that is fund that will go directly to that service. I'm not suggesting that they gain anything financially from that. I don't believe there is a financial gain because the work is still there, whether it's via a residential care provider or by the allied health provider, but it's about being able to ensure that you don't have to compete for the wrong reasons. And I think in terms of accountability measures for that, we should be accountable, but to the quality outcomes, to the clinical outcomes, and they should be built into potentially the aged care standards. I'm more than happy to have an allied health provider accountable to the residential care provider for that, but I think there's two levels of accountability. One is financial and one is quality. And I think where the financial targets are in place, then it makes it very difficult to deliver your service.
Thank you, Ms. Conchi. I have no further questions for you. Thank you all very much.
Thank you, Mr. Knowles. Commissioner Briggs, is there anything else you'd like to ask? Thank you. Well, Ms. Conchi, Ms. Violi, Mr. Young, thank you very much indeed for your assistance in all of this. You've obviously thought about these issues for a long time, and that can be seen both from what you've presented to us in writing and the way you've responded to these different questions. They're important matters, and we really do thank you very, very much for your assistance. I think I need now only formally excuse you from further attendance so that you can go about life freely. Thank you.
Thank you, Commissioner.
Thank you. Thank you very much.
Now adjourned till 9:30 tomorrow morning.
The Royal Commission is now adjourned until 9:30 a.m. on Friday, 17 July 2020.